Okay, I've just started the recording, Christy.
Great, thank you. Good morning, everybody. And just a reminder that we are recording this meeting, and the meeting will be available for viewing on our website in due course. But we also have so people observing us, of course, and particular welcome to any governors who are observing us. I believe Pat may be observing us today, Pat Marshall. So welcome, Pat, if you're there, and any other colleagues who might be observing us today. I just really want to, before we get cracking, obviously I'll note apologies in a short while, but particularly wanted to note that this is Julie's last public meeting. Julie Shepherd, our chief nurse, and I particularly wanted everyone to record that or note that as part of this meeting. So we need to be kind and gentle to her officially today. Not that we're not always, but I'm sure the board would like to just record its public appreciation, Julie, for everything you've done as chief nurse. It's been a wonderful journey that we've been on together, and a really huge thanks for everything you've done. I know there'll be much more of that as we go through, but I just wanted to record that. And also wanted to acknowledge that it's Linda's first meeting as Executive Director of Nursing. So congratulations, Linda. Big broad smile there. So really hugely important moment for you as well. So thank you. We do have apologies for absence from Dr. Itai Matumbike, who's our medical director, but I believe we have Sachin. Dr. Sachin Sankar here with us. Yes, hi Sachin. So Sachin is deputising today for Itai. We've also received apologies from Joanne Lancaster, Associate Ned. And I think that's all the apologies for today. So any declarations of interest for items on the agenda today, please? Okay, I'll take that as none. So minutes of our previous meeting, which is paper A. If there are any points of accuracy, first and foremost, I'd be grateful if people could identify them. I won't go through them page by page, but if you can signal if you've got any points of accuracy in the page number, we can make sure it's corrected appropriately. Everyone content? So on that basis, we'll approve the minutes as an accurate record of our meeting the 28th of September. Are there any matters arising? I think there's only one action outstanding, and that's the annual update from the Northamptonshire House Charity. I think it's a timing issue, isn't it? Looked to Dave and you. I think we sort of said this needed to happen in the new year now, and hopefully that will be possible to be scheduled. So we'll leave that on the action log if that's all right until that can take place. Thank you. Good. So and if there are no other matters arising, then just check our forward plan. I think we've got everything on the agenda that we were expecting today. Just make sure that everyone's content with that. And note that the the employee relations annual update, I think is going to the integrated assurance committee now. So that's to be noted. Okay, so that concludes the sort of opening section of our meeting, and I'm really delighted as ever to therefore welcome colleagues who are taking part in our patient story today. And at this point, I'll hand over to Anne to introduce it. Anne?
Hi, thank you, Krishni. So I'm really pleased to welcome colleagues from our children eating disorders team today. So Rachel Hickling, service manager, and Zach, one of our OTs, have come to talk to us today. And it's me and Scott shouldn't be allowed out on visits together because we were on a service visit, and we heard part of this story of something that didn't start off well. And I think it's, we hear lots of really great things, but there's always room for learning and growth and development. And this story really just brings forward how we just really accept and encourage feedback and how we grow from that. So I'm going to hand over to Rachel and Zach to just walk us through this story of a young person and her family. So over to you, Rachel.
Morning, everybody. I'm Rachel, and I'm the service manager for the Children's Eating Disorders team. It's nice to meet everyone. And Zach's my colleague. We have prepared some slides. So, Zach, are you able to share the screen and we can talk through them?
I shall certainly try to. We know how this sometimes goes. Bear with me.
The last time I met Rachel whilst Zach is doing that is at the Quality Awards, where Rachel was nominated for a leadership award, if I remember, Rachel. Is that right?
That's right. And the Eating Disorders team won the Excellence Award, which a lot of pride in the team for that. So
yeah, it was a lovely evening.
It was lovely. Anyway, boasting moment over. And I shall.
Can I just check that everyone can see the slides are up?
We can, Zach. Thank
Excellent,
you.
lovely. That's a good start.
So just moving on to share some background. This was a family that had made a complaint earlier in the year. A mother of a child who was a primary age child, and what she was sharing was that the 3 referrals had been made over a period of time and the family had been declined from specialist children's services, not just the children's community eating disorders team, also the complex feeding pathway and core CAMS, and not fitting neatly in any criteria. So this is Mum's words. So she's saying that she raised a complaint earlier in the year with regards to the care for her child. She complained that she hadn't been seen by anyone despite self-harming behaviours and showing very extreme behaviours, including it was drinking inedible liquids, as that person didn't fit in any of the teams. And from her perspective, she felt that she was being passed from service to service. So I'd already spoken to the mum at the point of prior to the complaint being made, and some of the actions had been put in place. But Zach, I talked to around his background in terms of OT, and he agreed to offer the child some intervention and further assessment. So I'll hand over to Zach to talk about the interventions, and then we'll move on to the learning from the complaint.
Okay. So in terms of what happened, excuse me. So as we said, with Mum and this young person, she's about 7.5 years old. And what we first wanted to do was actually just check to make sure that what was being observed did match up diagnostically with the criteria for PICA, which is ingesting non-nutritious, non-food items. Okay. So we met with her because she was a little bit nervous. She's also autistic, and obviously given Mum's experience with services, there was a degree of sort of caution. So we chatted, we completed the assessment. We felt, yep, that absolutely did meet the diagnostic criteria for PICA. The first thing we wanted to do was let's make this as safe as possible, as quickly as possible. So we identified what the most immediate risks were at home in terms of what she was ingesting or what she might potentially ingest. And we gave guidance around securing those, replacing those with sort of more edible, safe versions. We also looked at what was at school as well. So the first thing was the environmental assessment of risk. We looked at how we need to manage that. And also, obviously, because she goes to school, we need to make sure they're doing the same thing as well. We also needed to give Mum some education around what PICA is, also school. Because of things that are being ingested, we needed to be very clear about what the physical red flags were and what to do in the event of them. So the parents had only become aware that she was ingesting non-edible items earlier that year. So I think about February time. So although she might have been doing it actually for a considerable time before, they hadn't realised she was actually swallowing these items. Okay. So the next thing we needed to do was share all these risks, all the things we think we might need to do with the school to make sure they're on board. So we've got that wider environmental control. So then I started meeting with this young person and mum fortnightly, because we wanted to find out, okay, what is driving her need to ingest non-food items, to educate mum and dad what pica is, but also for this young person. She's actually a very articulate young 7.5-year-old. She's actually quite insightful in a lot of areas. It was very helpful chatting to her. She was actually able to start reflecting on when she had pica urges, when she didn't have pica urges, what she felt made it worse, which was really, really helpful. So through those regular sessions, we were able to kind of identify some of the drivers, actually. So there was a sensory seeking aspect to it to help regulate emotions, and lots of anxiety she was experiencing. We come to realise that the anxiety was around parental attachment, being away from mum. Lots of attachment issues, which was also resulting in other behaviours she was demonstrating. There was an instance of self-harm as well. We're able to kind of formulate that and put that into a kind of context. Fortunately, we haven't seen that happen again. The other thing that was kind of fueling the anxiety was the school environment, and maybe wasn't quite matching up to her needs, which increased the need for her attachment to the parent, which obviously increases some of the sensory seeking aspects of the pica. So we're working on that, talking through all those different ways to support her. There were simple things like her being able to recognise when she had a pica urge, and actually her and mum developing a code word, so she could then say, I'm having these urges, but she didn't want to stand out. It will draw attention to herself. We looked at creating pica box, where trying to replace non-edible items with edible items that reflect the sensory qualities of the non-edible items, if that makes sense, and making sure that these are accessible wherever she is. Okay, so whilst we're doing that work with pica, we actually started talking a little bit more about just general eating. We're an eating disorder service, it does come up. It seemed that she also might possibly have markers for ARFID, avoidant restrictive food intake disorder. So we actually did an assessment for that, and she also met diagnostic criteria given her restrictive or increasingly restrictive range of food she was eating. So we also then offered dietetic consultation to make sure she was nutritionally okay. We looked at obviously maintaining physical health monitoring, and then I started providing more tailored support around ARFID as well, because sometimes pica and ARFID, if we're trying to replace non-edible items with edible items, if they have a restricted diet, it can make it a bit trickier. So at the same time, parents felt that the school wasn't necessarily meeting all of her needs, so they moved schools. What we defined then was that the new school was very supportive and was maybe doing things that the other school wasn't able to. The young person themselves felt that they were more secure and felt more safe, and the attachment needs or the attachment behaviours that were being driven by the anxiety seemed to reduce. And what we saw was a significant reduction in pica and some of the other behaviours that she demonstrated around sort of emotional dysregulation and panic, those kind of things. So where we're at now is that her pica has reduced significantly from several times a day to 1 to 2 times a month, and they tend to be more when she's had a very, very difficult time. She's very distressed for whatever reason, but the threshold is a lot higher. Parents are now following the ARFID guidance, and their eating can be selective. They feel that they are confident managing this. They have a schedule now of trying new foods, reintroducing new foods, and we have a group that they will be joining.
I've just sent you an email.
Yes, do you want me to read them out to you now?
Chris, just pop yourself on mute.
Okay. This young person, she's autistic, and she still requires specific adaptations at school to optimise their learning and well-being, and that will probably be ongoing. She still experiences some intrusive, overvalued thoughts that can impact on eating and her well-being. So she has got a bit more focus now on risks of contamination if people touch plates and some of the rigidity that may come with it. So we're still working, supporting around that. But overall, in terms of, the pica, that has reduced a lot. Okay. So, Rachel, you want to take us through what followed on from the complaint?
Yeah, and I guess as the complaint was being investigated by a colleague, what we identified is that PICA's it's a presentation that people are aware of, but what we absolutely recognised was that no service was delivering an intervention. So there was further discussion with our clinical director, Gillian, and the agreement would be the community eating disorder service would offer that intervention. So that gave us an opportunity to really look at the wider service offer and start to create a pathway. So what we did was we had an integrated approach, because often these children, you might have some children that might have learning disabilities and some children that might not. So there's lots of reasons why children develop these types of behaviours. So it had to be integrated. So we linked in with community team for people with learning disabilities and colleagues in paediatric psychology and other services that support children. We developed a screening guide, risk assessment, and also Zach's done an awful lot of work here around the evidence base for treating, which is quite limited for PICA. We then went on to think about, actually, it can't just sit with community eating disorder service. It's a much wider approach. Health visiting might come across children, school nursing. So we did get some training in place, which was a whole specialist services approach, whereby lots of different professionals attended that training by one of the leading experts in PICA. And then Zach has done an absolute amazing job of developing PICA packs as a level of intervention. And actually, the lady that developed the training was impressed by what Zach had been working on separately and asked if she could use that in some of her national training, which was well done, Zach. And then what we did was we really fought with our community paediatrician colleagues within NHFT and wider professionals, think about what our pathway would look like to make it as robust and safe as possible. The risk for these children is very extreme at times. You know, worst possible outcomes for some children is they might require surgical intervention for obstructions in their gut, all of that kind of thing. So we had to be absolutely precise with what we were doing. I'll go on to the pathway, I will share it, it's on the next slide, but thinking about what's next for us, what we are doing is we're going to do an audit of the young people that have been accessing the pathway since we've operationalised it, just to sort of evaluate the benefits, but to identify if there's any disbenefits as well. Zach's developing a parent workshop, and also we're offering ongoing training for children that are supporting young people with PICA. Zach, do you want to do the next slide for the pathway?
Yeah.
Okay. Go ahead.
Okay, so yeah, so following all those consultations with members of our team, paediatricians, our PICA pathway kind of is as follows. So we'll have someone might suspect PICA. That could be coming through school nurses, it could be through GPs, wherever it's identified. We will get the referral through the referral management centre service. So we will then screen it through triage. Okay, and what we immediately do with that training, we get hold and we contact the parents, because we need to find immediately what is being swallowed, what the urgency of the risk is, the kind of things. We need to kind of get that safety advice out straight away, regardless of even any initial assessment. Okay, so we'll discuss what the risks are. We'll send kind of PICA pack, which has lots of guidance around safety management. We'll ascertain what they're eating, any developmental delays, any comorbidity around it, neurodivergence, what's going on in the family. In terms of causes PICA, there's a lot of correlation around sensory things around neurodivergence, but also around trauma, neglect, and things like associated sleep difficulties, things like that. We will advise on the physical red flags, again, to watch out for, advising that they're probably going to need to get their teeth checked out, because obviously if we're chewing non-edible items, we could be doing a lot of damage to gums and teeth. And for any other kind of medical issues we need to be aware of. We also will then look to exclude or check out if there is any nutritional deficiencies. Some drivers for PICA can be through nutritional deficiency. So we will explore all things like worms, infections, looking for obstructions, all the bloods that might need to happen, and liaising with any identified paediatricians that we need to make sure that blood work is done. Okay, what we'll also then look at is, do they fit within our service? What we've said is if there is actually a learning disability, then we'll probably be looking to work with our colleagues in the Children's Learning Disability Service to for them to work with them around the PICA, because there's likely all other areas as well that they're going to be best placed to support with. Okay. If we're looking at just PICA, then we'll probably look into liaise with colleagues in paediatric psychology as well. Also, if there is additional eating difficulties, we will then obviously be working with them, particularly around things like ARFID. Okay, so we'll do the assessment, we would do the PARDI, which we use to kind of just confirm the diagnosis and exclude any other reasons why it might be happening. We'll look at all the formulations, providing the psychoeducation, probably sensory support, things like PICA boxes, liaising with the school, making sure they're aware, as I said, what we did with the young person I talked about, and look at just more of a behavioural analysis. When is it more likely to happen? When is it less likely to happen? Trying to, again, work with the families to find ways, because they're the experts of their own child, to work out where the best way to intervene. Post-assessment, we would be referring back to the GP or the paediatrician to, again, let them know what we advise around monitoring, because we said PICA may not, can disappear as children get older, but they may not be in our service all that time. So we just need to skill up all the adults and all the professionals working around them as well. Okay, so yeah, that's kind of where we're at with the pathway. We try and make sure that we're assessing risk at the point that we're aware of these children all the way through. And at the moment, that is the most important thing, is just being very on it around the risk and the risk management and risk reduction. Okay.
And I guess to finish off, this is the feedback that we had from the people that made the complaint. So she wrote to say, I want to follow up on this complaint with a compliment. Not only have they been receiving the most fantastic support from Children's Eating Disorder Service with the assistance of Zach, but I've been informed that a new pathway has been established for young children with PICA, which means that no young person will be delayed receiving treatment again due to their age and or complex presentation. This shows an organisation who truly listens to feedback and responds to it. I can't thank you enough. On a personal level, our world is completely different to what it was in early 2023. My child feels listened to and safer, and that is due to the care and support she's currently receiving. And that's a nice place to finish.
Yeah.
Wow, that is fabulous feedback, isn't it? Really sort of heartwarming and somewhat tear-jerking in many ways, because the support for that young person feels quite profound, I think. And you know, what better investment is there other than in supporting young people to achieve better life outcomes? And at this early stage, Zach and other colleagues who were involved, you know, if intervention wasn't possible and support wasn't possible, who knows what would have happened. So it's an amazing story. Thank you so much for sharing it. It's prompted, as you would expect, lots of comments and questions. So I'll bring those in, Zach and Rachel, if you're comfortable to share and kind of hang around for that for a little while. Let's just bring people in order. So Angela first.
Thanks, Krishni, and thank you so much for sharing that story. I think it was firstly just to say thank you for the work that you're doing. It was inspirational in so many ways, actually, to hear. And just a few things that I thought struck me particularly was, one, the complexity, which I think the story illustrates very well. There's a lot of complexity, as you rightly know, and we understand more from what you've described this morning in terms of some of this work. The importance you have taken in taking the children, young people's voice, that is really powerful and obviously has made a big difference, which we've heard through the outcome that Rachel's just described. And I think the other thing that I reflected on was the fact that the complaint, it can be difficult when you get a complaint you can actually feel very challenged and concerned. And the fact that, again, you rose above that to then meet the family and this individual is really, really impressive. So thank you very much. It was really striking. Thank you.
Thank you, Angela. Julia next.
Thank you, Krishni. Hugely, very, very, very impactful story, and as Angela said, absolutely phenomenal piece of work, and what a fabulous example of integrated working. And for me, the word I wrote down through all of that was compassionate care, because you could have just said to those parents, I'm really sorry, we don't have a pathway for that, that's it. You absolutely grasped it, and the impact for children, you know, across Northamptonshire is going to be phenomenal, I'm sure. My question, I suppose, is, do you know the size of unmet need for this group of children at the moment, and how will the service plan for that? Because you'd put in all this effort for the resources. What's the human resources element for your team going forward if we're going to truly meet unmet need the next time, you know, a group of children come along like this? But just to leave the question there, but actually hugely impressive, and as Angela said, inspirational story. So thank you very much.
I think, Julia, it would be really nice to be able to give some response, because currently I think we anticipated quite a small number moving forward. However, post-COVID, those numbers are increasing, and it was crucial for it to be an integrated approach to include the community team for people with learning disabilities, because it's not an unusual presentation for children with learning disabilities. And I think moving forward, it's about maintaining that element of learning across all of children's services, and probably into adult services as well, because it has to be everybody's business, not a singular team's. And I think our ambition is to continue to work in an integrated way and continue to have those discussions, but also be able to support with any consultation and interventions. But the response from colleagues has been absolutely fantastic. We're at the point of getting the pathway signed off now, so and move to further develop as required. But we've got currently about 25 children between the ages of 3, 4 to 18 that meet our criteria currently. But I'm sure it's a much bigger unmet need there. But it's becoming, there's an awareness growing across all of our services.
Thank you, Rachel. That's really helpful to understand. And you know, 25, even 25 sounds like quite a sizable number, doesn't it? And as you say, there's I'm sure others who are less aware of this particular difficulty that some young people might be going through. So education is probably part of this, I guess. A few more comments to come or questions. Robin, next, please.
Hi, brilliant work, Zach. The pathway looks absolutely fantastic, and the work you've done looks really good. From previous experience, I don't think this is that uncommon, really. I think PICA is more common than people really think. I can remember very well working with it in an earlier life. But a question really to you and to Rachel. Was it specifically because this was a PICA case that this didn't get picked up by the other teams? Was it specific to the PICA thing? Or was it something broader as to why, unfortunately, this family went through, she says, 3 teams before she got to the help that she's now got from you? So is there anything else to draw out from that?
I think the learning from the complaint element was around the complexity around not just PICA, but a self-harming presentation. I think that made it more difficult for teams to unpick. I think the learning from there was about those discussions to happen across services to enable these things to be picked up in a timely way. And I think we're much better at doing that generally now anyway.
Thank you, Rachel. David?
Thanks, Rachel. Thanks, Zach. Really useful story. I just thought I'd share with you one thing and also to share that with the board. I know that the Department for Education and NHS England are really interested in developing a pilot project about more resilience and support we can provide to schools to support people with neurodiversity in schools. So that's just about starting, and there were some initial briefing meetings about that this week. There'll then be a process which systems can go through to acquire some additional resource and support and take forward a programme. But I think the initial programme in each system is looking at how we can support a minimum of 40 primary schools. So that doesn't solve your problem today, but that's some of the wider system support that we can influence and take forward over the coming year or so, and hopefully help build resilience. Because I spot one of the issues there is about helping schools understand how to support people really well.
Yeah, helpful. Thank you, David. Tim, next, please.
Yeah, just well done, firstly, guys. It's an amazing job, but I loved the way that you logically and considered the response and broke it down in a way that meant that, because quite often the response is emotional, and you really helped the family and the parents. So thank you for that. I also really appreciate the fact that it was a learning experience, and then others are going to benefit from this. It isn't just a one-off intervention. I'm just curious about how much resistance you get to that sort of, I want to make a change and this is the new change we're bringing, or was it very straightforward because of the emotion wrapped up in it?
I think we're quite, I don't know if Zach would agree. I think it gives an opportunity just to think about how we meet a need within a service, because I think, as other people have said, these children were there. And I think being able to provide the wider training from a national leading expert who kind of gave us confidence in what we were doing as well. Would you agree, Zach?
Yeah, I'd say confidence was the big issue, certainly for my colleagues. It was, well, actually, there's quite a common sense approach to this as well. As if someone's eating stuff, first of all, let's move that stuff out the way, But sometimes people feel, oh, this is outside my wheelhouse. I don't know what to do. They're eating. What do we do? Well, let's just bring common sense into this first of all, which lots of the parents do. And then let's start unpicking it, because if we're constantly fighting fires about, like you say, hospital appointments, all that risk, then we're not going to be pulling apart anything else, because we're just going to be panicking. In terms of resistance, I don't think so. I think we just kind of went, it was more, how do we do it, rather than should we do it, can we do it, which is, I always like the how questions rather than the can questions, because you tend to problem solve around it. And I think, yeah, that was it. It was more just who do we need to involve, and actually, as we said, we need to recognise in that integrated approach, because otherwise it's going to get very challenging in our service. And actually, as I said, with someone maybe who best fit with a learning disability service, we're going to work on the PICA, but there's this all other areas of support that we probably wouldn't do, and that's going to be at that person's or family's detriment.
Yeah,
and everyone benefits from learning new skills, don't they? So
brilliant, thank you. Scott, next, please.
Yeah, thank you, Krishni. Hi, Rachel. Hi, Zach.
Hi.
So as Anne said at the start, she and I genuinely shouldn't be allowed to go on service visits together. We just end up dragging excellent people like you into the spotlight, even though you probably aren't seeking it at all. I mean, look, a number of things I want to just reference. Right. First of all, absolutely no surprise to me that that Rachel and the team have won an Excellence Award. Right. It just gave that feel from the moment that we arrived there. So, but what I do want to sort of reference just for a moment is winning an Excellence Award against the backdrop of a genuinely excellent organisation is no mean feat. Right. So for a start, that really felt well deserved. I came out of the service visit absolutely buzzing about what we'd seen and what we'd heard, so much so that about a week and a half later I raved about it to Krishni during my interim one-to-one. So I think I bored everybody in the interim period, but it's just a really perfect example, right? So we met lots and lots of people whilst we were there on the day who were really impressive, but if I just take a moment to reflect on Rachel and Zach, right, and just give them a bit of uncomfortable focus for a moment, right? So the perfect yin and yang, right? So Rachel's absolutely got it going on. She's running the whole service, to an exemplary level, like clockwork. And Zach's just like this wall of enthusiasm that you kind of, just rocks you back on your heels. So just picking up from what Tim said a minute ago, good luck to anybody who wants to resist anything that those two have to try and propose to you, because I just don't think it's going to work. So, I mean, final couple of comments. I want to try and be a little bit more constructive in all of this, right? For me, it's no accident that Zach's an OT, right? Because he's approached it like an OT, He's absolutely segmented it, dismantled it, taken it back to the things that need to be done, and he's paid attention to it. You know, Rachel's given him the room to fly in that and supported all of that activity. It's fantastic. So for me, this is a perfect example of innovation in action, folks. There was a gap, there wasn't a pathway, they weren't daunted by that, so they created one. Right, that's really, really impressive. And, you know, I think they're now getting the recognition that they deserve, both here, but also on a national basis, for the incredible work that they've done. It was a real privilege to meet with you guys. So thank you. It was an absolutely stunning service visit.
Well, follow that, Sachin and Saqib. Thank you, Scott. No,
Yeah.
lovely that, you know, you had that opportunity to interact with the service and then kind of want to see it. And I think important because this didn't start well, did it? And I know that's not something to celebrate, but actually it is important that we recognise there were some real challenges here for the person who was seeking a service. But it's, as the feedback said, it's how we then responded to it, and that's what a really a learning organisation needs to do, and you've exemplified that. Sachin, please.
Yeah, thanks, Trishni. So I just wanted to highlight, I think I am a perfect person to follow Adam in praising this team, because I think this really highlights some of the, you know, excellent values that we have, and I think in our service. So the first thing is that pica is actually more associated with learning difficulties. And if you think of anorexia nervosa, it's quite a few miles away from what this team is actually commissioned to do. So they have, you know, and I think the uniqueness in our trust is that we have a really patient-focused approach as opposed to a team-focused approach. And the initial issues that we had, I think, are more due to the dynamics of trying to find the best person to deal with it, because this is always the issue we have. Who is the expert in pica? Should it go to learning disability? Should it go to eating disorder? Then I think once it became clear that there was nobody to pick it up, the eating disorder services very quickly moved into the gap to pick up and offer this service. So really, you know, that compassionate care that Julia was talking about. So I think it's really that in action. And again, Rachel's comment and Zach's comment that once it had to be done for the patient, it had to be done. You know, I think in our trust, it's not acceptable for people to say, oh, it's not my job or whatever, you know, if something needs to be done. So I think these are, you know, really excellent examples of why we are an outstanding organization. So, yeah, thank you.
Thank you so much, Sachin. Well followed indeed. Saqib, and then I will I'll bring Anne in to close the item. Saqib.
It's getting tougher and tougher, isn't it? I mean, everything's already been said potentially, but what I would say is, you know, it was, thank you for doing an amazing job. I think from a quality improvement, you followed all the right methodologies and, you know, learning from what's going on, what you can do, how to do it better for the next time. I think that's really insightful. The other thing I just wanted to ask, and Sachin kind of mentioned it, had the patient been non-vocal or unable to explain, would the pathway have been similar, or are there learnings you can?
I think the pathway would have been the same, because obviously we're following kind of what evidence there is. It was very helpful just for Percy Spirit to understand what it is like for someone with pica, because she was actually able to express, she describes it, her head gets full, and that is almost all she can do. It's like having an itch that you kind of almost reflexively scratch. So from my personal understanding, it was great, and also just to get to know this young person and kind of what it's like being her, it was incredibly helpful. And, you know, that may well apply to other children. We have a couple of children with pica who are non-verbal, and that is harder. In terms of what we're going to do intervention pathway-wise, I don't think it would have changed, because we can't just follow, just one person's story. We have to look at that sort of broader sort of clinical presentation and what's been tried before. So yeah, but it was just from my personal understanding of what it's like to be 7-year-old with Pika. It was actually really helpful. She's very articulate.
And has the school been really supportive? I mean, you mentioned to have access where you...
the first school she was at, they were helpful around some of the Pika, so they were very much aware of the risks. A lot of the issues that were driving the anxiety and the attachment, so there was some sensory seeking needs. She found it very difficult to eat because of noise, sensory sensitivities, and just general, I don't want to be around people. They found it harder to meet those needs, which I think did perpetuate, again, this is not a safe space for me, this is a difficult space, so I want to be with mum, and all those kind of thoughts. She then moved to a different school this year, and when she was at home, what we did see was a big drop in the Pika, because I think she wasn't at school. So I was kind of anticipating when she started new school to ramp up again. But the school were all the things that the other school felt they couldn't do, the school felt they could do. I mean, I can go to listen, but time-wise. But yeah, so the overall upshot is that she felt, I think, more secure, almost with non-Pika related support.
Yeah,
that makes sense.
Thank you, Zach. Sachin, I'm going to unfortunately to bring this to a close. So Sachin, very briefly, if you wouldn't mind.
Yeah, so I just wanted to say, to kind of respond to what Sakiba said and what Zach has said, in children, we need to think of network of care. So it's, it's really good that we have Zach, who's kind of a network in himself, like he is an OT, so he has that kind of sensory integration thing, but he works in the eating disorder service. So I think these innovative solutions are possible because we have innovative solutions, but otherwise it would have involved somebody from the learning disability service providing that sensory integration work, and especially in non-verbal children, that's quite important. Thank you.
Thank you. Thank you, Sachin, for that. Really helpful. And there's some, other comments in the chat box about how, the nature of the story and the compassionate care that you provided. So it's been a really illuminating, I think, but very, very striking story. And we really appreciate the time, Zach and Rachel, that you've taken to come and talk to us, having already spoken to Scott and Rachel on that obviously very inspiring visit. And is there anything finally that you want to add?
Yeah, I think the only bit that hasn't maybe necessarily come through from the questions is how much this is, as I say, that network. So they might have picked up, been agile to pick up the patient need and the family need, but haven't necessarily assumed that everything is needs to be done in one service. It's about making sure that people are treated in a variety of services that is suitable for them. And I think that's the beauty of this learning and development as an organisation.
Brilliant. That's a great note on which to finish this patient story. Thank you again, Rachel and Zach. Lovely to see you. And thanks so much for joining us today.
Thank you.
Thank
Bye-bye.
you. Bye. Brilliant. Right, on that very powerful note, we will move on to our other sections of our meeting today. So the first item we have coming is our risk section of the meeting, and we have the risk report, which is paper D. Richard, do you want to illuminate anything? And I just really, in the interest of time, just ask everyone to sort of keep things to 2 or 3 minutes, please, if you wouldn't mind. And then it just allows plenty of time for questions, which is the main thing I'd like to encourage, really. So that's okay with everyone. Over to you, Richard.
Thanks, Krishna. Yes, with reference to paper D in the pack, the board will see we've taken a further step towards embedding our new board assurance framework. What we're seeking to achieve through this is to illuminate the overall level of risk to our delivery of our strategic objectives, sharpen focus on the effectiveness of the management of risk, not just the assessment of risk, and to stimulate a more sort of forward-looking discussion about the impact of risk on the delivery of our future plans. The report therefore attempts to provide that overall assessment and breaks down risk by strategic theme. There are details obviously contained within the dashboard appended to the report. It's probably just worth noting before I hand back, Christy, for questions, that board committees have received much more detailed information on the individual risks, which include controls, assurances, gaps and plans, actually. And it is something that we will then be seeking to incorporate in future reports to the board, conscious that not every board member attends every committee, and therefore the board needs to understand some of that detail in order to feel assured overall. So just to finish off then, I think the report demonstrates that whilst the overall level of risk to the delivery of our strategy remains relatively high, we are nevertheless making good progress on our risk management plans at this point in the year. So I'll hand back to you, Christy, to facilitate discussion and questions. Thank you.
Thank you, Richard. So, colleagues, Judith.
Good morning. Thank you very much, Krishni. Richard, great paper. Thank you. Just a couple of observations. Although I do like the BAF, I am missing the slightly more granular understanding of the really big risks underneath this, but clearly that will come out from committee discussions. And I've got a couple of observations in relation to the risks BAF 5 and 7. BAF 5, as far as I understand it, relates to our estates strategy. I think we need to wear the lens of a stranger coming into the organisation and reading that cold. And if somebody reads that cold, that does not shout estates planning, that shouts something different. So I would suggest perhaps rewording that so that it is actually clear that that's what we mean, but that's the risk that it's related to. And BAF 7, again, it's a wording issue. I understand what the risks, what it is that we're trying to cover off here. However, I'm a little bit concerned that we're actually referring to the lack of connectivity of population health management across Northamptonshire, which I'm not sure we necessarily have too much control over as a trust. I mean, we're involved in that, but that's more, from my point of view, more of an ICB risk. So again, we need to perhaps rein that in a bit. So BAF 5, reclarify, BAF 7, rein in. Thank you.
Thank you, Judith. Richard, shall I? I'll let colleagues come in on those points if they want to, the risk owners, because I'm conscious that some of that will be risk owners to respond to. But perhaps before I bring Paul in, if it's all right, Paul, I'll just get Robin to respond to raise his as well, and then you might, because there might be other similar comments that you might want to pick up. So Robin, next, please.
My point was just simply about the trend over 6 months or longer. Really helpful to see how these risks have changed over time, rather than just see it every time as a snapshot, because it tells us much more. We've been doing a similar process, I note, in the ICB's quality committee risks, looking at them over in fact a 2-year period, and it's really been helpful. So it would be really helpful to see it here as well. That's all.
Thank you, Robin. If I may make a couple of comments myself, in case Dave and Paul would like to pick any of these things up as part of that, or any other colleagues around the room. So I think I just wanted to, in the scheme of things, and I'm very happy to have a sort of conversation about this, but I felt I welcomed the sort of overarching risk description actually around each of the strategic themes. That felt some interesting and stimulating in terms of being able to think that through. I did wonder whether it's right for us as a board to consider the innovate risk as significant and at the same level as our workforce risk. As a general proposition, I think that's something we should debate. Because it's something already we have a relatively high risk appetite for. So it's a challenge I would put back really to perhaps executive colleagues, just to ask that question, and to other colleagues really. I mean, others might think it ought to be that high, but in the scheme of some of the other risks, I wasn't absolutely convinced that Innovate should sit as a significant risk. So maybe interested in David or Sachin's comments on that in Itai's absence. More generally, I think picking up on what Judith said, I think we do need to see a little bit more about sources of assurance and gaps in assurance at board. And I did share that with Richard beforehand. I do think for not all colleagues around here attend every committee meeting, and therefore visibility of that I think is important to the board. So a level of detail on that, obviously have to get that appropriate, but I think there ought to be a little bit more on that. And I think more broadly, I'd just encourage a bit more consistency around the way the risks are, the BAF risks are presented. We in the process of development of these risks, I think we've lost the if and then. I know it's a little bit what's the word, sort of perhaps a bit too, it might feel a bit much of a straitjacket, but I think it helped to really be clear what we're saying in terms of the nature of the risk. So, and I think we've done that before, where we describe each risk as, if this happens, then this is the consequence, and I did find that wording quite helpful. So, but I recognise as part of the development of this process and document. So it's just, I think, ongoing work that we need to do, but just some reflections that I had already shared with Richard. Paul, do you want to comment on the estates risk inverted commas?
Yes, exactly, Krishna, and you and I, and indeed anybody else who's interested, we can talk further about this. But what I wanted to say was that we'd lifted some of the wording from the NHS England standard wording that they use. So things like therapeutic environment might feel a bit not what we do necessarily, but it is reflective of national language. But we can certainly modify it. Krishna and Judith and I can have that conversation. We can bring something which is more acceptable for sure.
Thank you, Paul. And it is consistent, I imagine, with what we've said in the group strategic priority as well, isn't it? So it's just thinking about sort of balancing the two things, really, but I will leave you to consider that. Dave?
Thanks, Krishna. So David's picking up some of the comments around the Innovate risk. So just on BAF 7, agree with the overall thrust of the feedback. I mean, I think what we're describing there is the NARP gap, so the Northamptonshire Analytical Reporting Platform, which is just now gaining traction, and hopefully will begin to feed into our planning so that we get kind of decisions made around relative priorities, which are based on population need and feedback from provider organisations in a more detailed way. So I agree, we could probably do one that looks outward into the ICB, which relates to pathway planning, and one that reflects inwardly about how we use our own data to drive our own planning and to support our patients and staff. So yeah, just to confirm that we'll look at that.
Thank you, Dave. Julia, I think you wanted to come in as well.
Thanks, Christian. Just really quickly, just to say that, building on one of Judith's points, you'll see later in the papers from the Quality and Safety Committee the escalation and summary report, but we actually rated the BAF currently as advise, and that's mainly because the BAF risks around quality have become very broad, rightly strategic, absolutely, and we support the transition and really recognise the huge amount of work going on in this sort of development phase. And as it's maturing, I think at the next committee we'll probably be seeing some of the corporate risks that underpin the main strategic risks, and I think having in that transition phase, that's why we've rated it as advise only this time, because I think that will help in the assurance process going forward. We like the risks, but they've moved to quite broad risks, and it's just in that transition period. Just wanted to mention that. Thanks.
Yeah, thank you, Julia. That's helpful, and I think it's a recognition that there is a lot of work. This has been a development process that we're all part of, but all been part of through the board development conversations, but also now through committees, etc. So it's refine and improve. I think that's where we are, isn't it? David, are you able to share a perspective then on the innovate risk?
I think I'd say more than happy to go back and have an exec conversation. We're doing some work next week on strategy, our ways of working through. So it's probably the best way of taking it forward would be for us to sit down and have that, use today's conversation as a way to say, do we all feel that's the right scoring and the right way forward?
Yeah, great. Super. Thanks, everybody. So a great development to see this sort of coming to life in a different way, and as we've said, some refinements to be done. But I think we've agreed some actions to take forward to address those. So thank you very much, Richard and colleagues, because I know this is a joint effort in terms of that ongoing work, and so we've considered the report and we've identified areas that we think it could be enhanced. So thank you for that, and I think, Richard, that's all you wanted from us today. So we'll move on to item 8.2, which is an opportunity, Anne, if you want to just provide us with any update on winter plans and COVID-19 situation.
Yes, just very briefly, as I know we're short for time, that in relation to COVID, I think we've seen generally in our presentations, there's been a decrease nationally. That's you'll see that later in Angela's report, and also flu's reasonably stable, has been. But what we're seeing, we saw last year, was that increased later in the month. So I think we're kind of keeping ourselves ready for an increase in activity as winter really gets a grip with us in the next few weeks. So at the moment, I'm not seeing any particular hotspots regarding COVID, and we are winter ready. We're sitting at an Opal 3 for a majority of the last week as a system, which is positive. The schemes that I think are really supporting some of that is some of the work we've already done, and I know we've got more work to do, but that we've already done on Pathway 2 is supporting that, and also how we've been working with social care on really improving some of the Pathway 1, which is people who leave hospital with a support package. So I think we're in a holding tight position at the moment as our plans sort of unfold and we get into more of the heat of winter. But that's really what's happening in the system at the moment.
Thank you very much, Anne. Any questions for Anne at all? And I suppose the only thing that struck me is that I guess if less and less people are testing these days, we won't really know if it's COVID at all, will we? In reality.
Yeah, and I think a lot of what we discuss in the system around winter is around respiratory flu symptoms and presentations. It's much more becoming the language rather than defining down unless you get an outbreak somewhere. We did see a slight peak in paediatrics a few weeks ago. I think that's it's telling in the schools, but there hasn't. Without the testing, it's really hard to know in the same way in our communities. We can only tell when people have then come into hospital. But that's I think that's something that we will kind of have learning to live with, that enmeshment of respiratory and how we manage that.
Yeah, helpful really, because I think that probably ought to be reflected in our, as you say, in our language, and even in the update we're seeking to get from you at our boards as well. It's perhaps less about COVID now and about our winter preparedness as it's always been in many ways. And it just struck me that I think I was conscious that quite a few people had been unwell, but and they thought it might be COVID. I mean, not necessarily on around our board, but they weren't sure anymore. So it's just an interesting observation, really. Thank you, Anne. Helpful to note. We move on then to our Alert, Advise and Assure report from the Integrated Assurance Committee, and I think this is over to Tim. Tim, this was your first meeting, I think you chaired, of this committee. Was it, or is it? Was it?
It certainly was. Chaired in the loosest sense. I had control for moments. I think the report breaks down effectively into 3 areas now, and I'm going to just take it away from the report itself, so we'll take that as read. But effectively, the alert is around the finances, and this was pre the NHSE letter. And we know that there's a lot going on in this space. So this was about our financial targets and trying to achieve them, and agency spend clearly was the target of that. Under advice, they tend to be the people-related things, focused on sickness in our staff or our ability to recruit people, and where we're operating at full capacity. And when we are losing people, are we losing? You don't lose them in a planned way, therefore you end up with peaks and troughs in teams. So that's kind of the people part of it. But the workbook dashboard does pull all that together really nicely, and the trend analysis helps you find your way through that story. But we know there's work going on. But then the assurance, where we got positive assurance, was around all of how we operate. So whether that was safeguards, safe working hours, there's really good assurance going on in that place once you've got people in and working. That's it.
Thank you, Tim. Really helpful. Any questions? So just one observation, I guess. I don't know if there's this may not be, this is probably not easy to answer, but on BAF 3, there's a reference under the advice section of the report about the increase in acuity of referrals into staff wellbeing services was highlighted. And Chris, I just wondered about whether we're seeing an impact of the hub closure at all, or whether that's not a factor in that, because would it have been routed through, or would we have seen it differently? I wasn't sure, so just thought I'd ask that question.
Yes, we have seen an impact of that. I think the environment that we obviously talk about in the BAF is a big factor in that. In terms of the process of managing the system stronger together, closing or reducing, we have been able to relocate some of those staff into our own wellbeing service, which we, on the back of discussions, we've invested some monies in, and also they've won a tender to provide some support across the East Midlands. So we have seen that, but we've put a number of initiatives in place to respond to that, and we'll continue to do that, and we discussed that extensively at the wellbeing group. So the answer is yes, but we've taken further action to take support and put it in place. Question.
Great, thank you, Chris. Really helpful. Thank you, Tim. Well done chairing your first meeting as well. A very good report. Thank you. So moving on then to our strategy section. First of all, Angela, is there anything you want to share verbally before we get to your Chief Exec's report later?
Yeah, just 2 items just to update the board. Last time I think I shared that there was interviews ahead for the LLR, so Leicestershire System ICB Chief Executive. That appointment has been made on an interim basis, and that's Caroline Trevick, who is and was the chief nurse in the system. So used to working with Caroline, and also just to confirm that Richard Mitchell, I spoke last time about the collaboration across University Hospitals Northamptonshire and University Hospitals of Leicestershire. He is now confirmed as the chief executive across those organisations. Thanks, Krishni.
Thanks, Angela. Okay, so we'll move on to my report, which is paper F. Really just wanted to highlight the Cransley Hospice event, which Julie and I attended. It was really lovely celebration, actually, and lovely to have so many of our staff there as part of it, and being recognised, I think, for their contribution. And very much seen as a partner event. I think it's important to say that. And therefore, you know, we had collectively an opportunity, along with colleagues from the Integrated Care Board, to be presented to His Royal Highness. So it was a really lovely event, and I think very welcome, and a great opportunity to, as I said in the report, to meet our staff who were part of the event. So that was good. And I also wanted to mention, Anne and I had the opportunity to go to the Developing Aspirant Leaders celebration event. It was sort of like the graduation ceremony, if you like, for colleagues from around the Midlands, but our own Simba Capiche, who it was our crisis services or crisis house manager, wasn't she? But I think she's been promoted in the meantime, which is actually celebrated in the event, because in itself, I think there was a great sort of sense of, well, colleagues who've taken part in this wonderful programme are developing so incredibly well and achieving really good personal outcomes along the way. So it was really lovely to be part of that, and to see, and for those who aren't aware, Developing Aspirant Leaders is a sort of programme of development for people from diverse backgrounds across the Midlands, and all nurses, I think, by background, so sponsored very much by the Chief Nursing Officer for the region. So it was a lovely event, really lovely event, and I know Simba enjoyed it. And of course, we had the privilege of supporting Amelia through it previously. So, you know, two great successes from our point of view. And we are very much trying to encourage the region to continue supporting that programme, because it's been such a positive experience for people who've taken part. On a practical note, just wanted to welcome Sharon Madeley, who will be joining us as a public governor for Kettering and Corby, and I think following an induction, so look forward to that. And really just wanted the board to note the non-executive director roles and responsibilities document, which is associated in the report as Appendix A, particularly really planning ahead to sort of handovers. Unfortunately, need to highlight that at some point we do have to part company with Scott, who it's not immediate, but it's some months ahead. But as you would expect, we're sort of in the planning of just trying to make sure that there are some transition and handover plans. There's some discussions have taken place about deputy chair for performance, and also the LGBTQ network sponsor, and at some point Scott and Joanne hopefully will work out a handover point for those two things. And also wanted to mention that I think Joanne will be also, if you could sort of support her with her service visits as well. So those were a couple of changes, but just thought it was important to put that to the board for the record and for support, really, because obviously it's important that everyone's cited on these changes that are taking place. So any questions? You're happy to move on? Okay, so I'll take it that the board supports those changes, and hand over to Angela for your report, Angela.
Thanks, Krishni. And I'll just highlight a few things or additions to the report. But just to remind people that we have now got a new Secretary of State, the Right Honourable Victoria Atkins. So that's have been a new addition in the government reshuffle. I know people will have seen that there is a CQC annual state of care report. I would encourage people to read that if they've not had chance. And I think important to recognise the increased mention of demand and pressures on staff, which I think is significant. And I think, again, through our staff survey, which I'll come back to, that will be an opportunity for us to understand that in a more depth way within NHFT. There is clearly a mention of our quality awards, and we've mentioned them already this morning, but I just wanted to not miss the opportunity to say thank you to everybody who nominated colleagues across the organisation. We had more than ever, which is fantastic. We also had a face-to-face event, which was lovely, and a thank you to our comms teams who really did deliver for us on that night. So thank you to everybody involved in that. Really pleased to see some of our medical staff getting profile across on a national basis. So thank you to them for doing that. And I think particularly congratulations to Dr. Lily Reid, who was awarded a President's Medal recently. I think it's great to see that, and she is really championing a lot of work for SAS doctors as well, which I think is really, really encouraging for us and for national colleagues. Mention the staff survey. I think very pleased to say that we have achieved an increased response rate across the organisation. It's 59.6%, which is a great result, I think. I'm sure that is going to be well above average, but we will wait to see that relativity. But really important that so many staff have taken that opportunity. We've also slightly increased the response of our bank staff, which was 26.9%. So again, good to see that that has increased. We will endeavour, of course, to understand that staff experience, and that will come back in due course. But really pleased, and thank you to all staff who took the time to do that. Again, just wanted to highlight that we're really encouraged that we've got the National Preceptorship Quality Mark. I know it's in the report, but again, thank you to everybody who's been involved in that. That is really important to achieve. And my final note is just to mention Julie, as you already have, Krishni. I think it's very important for me to put on record the enormous thanks to Julie for her personal leadership over 10 years. Actually, in this organisation as the chief nurse. It's an incredible legacy that she has driven, led and leaves for the organisation. I've worked with her for those 10 years, so I'm probably more privileged than most to have been in that position. But it is really an incredible achievement, and I think it goes without saying that I will miss working with her. I know we all will, but thank you very much, Julie, and well done. Thank you.
Thank you, Angela. Thank you.
I think we would all echo that again, Julie, and we're probably going to keep saying that for a little bit, but rightly so. Any comments or questions on Angela's report? I just want to pick up on the staff survey response rate, Angela. If I remember, it was 48% last year, so that is a significant increase. And a great credit to everybody. Well, somehow, you know, at these very busy times, encouraging people to contribute and making people want to contribute is so important. So that is really, I know 48% was a bit of a unusual dip for us because we'd always historically been better than that, but that's really quite a significant improvement. So that's very encouraging, because at the end of the day, you know, the results, the more people tell us how they feel, the better we can respond to it. And you know, whatever feedback there is, it is so important that it is as representative as it can be of all the staff that we employ. So that's really good news. So thank you. Thank you, Angela. If there's no further comments or questions, then we will move on to paper. Our next paper, paper H, which is the DigBQ update. So, David?
Thank you very much, Krishni. Thank you all. So just a very brief summary. We have the report in front of us, which is an update on the achievements made through to Q2 on DigBQ. So that's our strategy: develop, innovate, grow, build and quality. A couple of just highlights that are there on the header report for us about the successes we've been moving through, some partnership working, continue to do with our review work, and picking up the things around the group priorities. We'll touch more on those when we come to our group highlight report later on in the meeting today. Some good work there on grow, and some further work there developing the sustainability and build. I thought I'd just very briefly highlight that in build, one of the opportunities that's come towards us is Manchester University undertaking some NHIR research into NHS Trust sustainability. And by accessing that research, we've been able to feed our data in, and we will be getting a report back about our sustainability impact, about the amount of money we spend with local suppliers, about the impact of how many people we employ locally. And all of that was an action that we were planning to do for ourselves. However, with a value programme and a way of thinking things through, we were trying to think of alternative ways of doing it. Becoming part of Manchester University's research programme means we get all of that as a free source by providing them with the data. So that's been a nice way to save some resource inside NHFT and get some learning that will then be benchmarked to others. And the only other bit I just wanted to mention was that in producing this report and thinking through the strategy and understanding some stuff, we've had some internal conversations, not yet completed, but are clear that what we're doing at the moment with this report is it comes to multiple meetings in the same format. And I think the bit I want to think about as we go through into NHFT and our strategy from the 1st of April 2024 is how do we bring to this board an assurance and an update of our strategy and progress, rather than a repeat of a paper that's been to some other meetings internally, strategic exec board and ways of feeding stuff through. So I'll update you all about that in advance of the new financial year and understanding the strategy and the annual plan for that. But just wanted to think through, I think we've got to help the board be able to get clearly into the assurance of the deliverables rather than just information about all of them. I hope that helps, and happy to pick up any queries or questions.
Thank you, David. Very helpful. Any questions or comments? Judith?
Thanks, Roshni. David, thank you very much. Really clear report. I really enjoyed reading it. It's really an observation, and it ties in with Roshni, your comment around innovation earlier about where we are from a risk rating point of view, a risk level point of view. I've had the opportunity of doing a number of service visits recently, and without exception, every single one of the services I've visited are doing something really quite innovative, either the first in the country or the first few in the country, or they've come up with their own idea and it's not even been sort of mapped as to who else is doing it in the country. And I think we shouldn't sort of beat ourselves up too much on this innovate bit, because I don't think any of that is actually being recognised or tracked under the innovate bit of the Dig Big Q strategy. And I was just wondering if it would be possible to somehow reflect this or give ourselves recognition, because the teams are getting the recognition, but I'm not sure at board level we're really accepting that that the services are doing some fantastic work individually. Thank you.
That's absolutely fine, Judith. Itai and I have had a conversation recently about how do we ensure that people are aware of everything that's happening, and that's partly internally to make sure that learning that pops up in Team A is actually shared with Teams B, C, D and E. Is also things that then we're aware of as an organisation. So it is one of the things we've been talking about.
Thanks, David. There's something about case studies, I think, that, of course, there will be some formal evaluations, won't there, for, as in sort of, I think, I was trying to think that body-worn cameras is an older example where I think, did a published piece actually on that. But I think even when there aren't those sort of formal evaluations, some kind of case study approach, which actually allows us to capture this really good work and tell the story really well in a sort of, on a page, story on a page type thing, which I think we're really good at as well. I think is quite powerful. It's a bit of the same thing around how do we capture all the good work that goes on in between the two organisations in the group. Some of it is organic, isn't it? And capturing it under a formal sort of header is actually harder. But it's a nice place to be, to even be having this conversation, Judith. So thank you for sort of highlighting that, because I think it's such a positive thing that actually we're seeing these examples, and we're just thinking about how we really recognise and capture those, and perhaps formally, a bit more formally, really. Okay, Scott, please.
Yeah, thank you, Krishna. So I think I'm going to end up making a kind of similar point, to be honest, because first of all, David, I also wanted to congratulate the document. It gets across an enormous amount of information in a very tidy, very succinct fashion, and you're telling a very broad and very deep story, and it comes across, you know, in an easy to digest format, and that's not easy to do. So thank you for that. That's the first thing to say. I think a bit like Krishni and you that have just said, I think we need to just loosen the reins a little bit on ourselves as what we're prepared to call innovation, because, you know, I think it doesn't all have to be clinically led or academically led. You know, we've had some fun. I mean, I hadn't even considered the dimension that Krishni brought forward about the fact that we are making a partnership arrangement work in a very effective fashion. But I wanted to support the point that you did, Met. Even our patient story this morning was an excellent example of sort of team-led, bottom-up innovation, and the sort of stuff that not many organisations can actually claim to deliver. So I think we just need to, you know, give ourselves a little bit more slack on that and actually start counting it under the innovation umbrella. And I think our scores in that area would rightly go up. We're probably being a bit severe on ourselves.
Thank you, Scott. Julia.
Thanks, Krishni. I'm probably just going to echo all of that. Definitely the report is maturing really nicely, and it is a joy to read. It's simple, easy to understand, and really helps us sort of crystallise and condense our thoughts around our strategies. I was just thinking that research and innovation sits in a report a couple of times a year to the Quality and Safety Committee, and it often does focus on the formal research programmes that we have. And so I'm just sort of throwing it out there to think about. We obviously have transformation committee, we have quality and safety. There are lots of different places it can go, and I love the idea of the stories and the vignettes and the, you know, short, sharp studies. And just to put it out there that we'd be very happy to receive some of that information in any way, shape or form that helps bring it together in one place, because a lot of it's quality improvement too, quality improvement activities, and all links into the reporting that's been coming through. So really happy that with whatever's decided, but I like the idea of sort of strengthening some of those stories and information coming through. That'd be great. Thanks.
And Julie might want to be sort of echoing some of that, I suspect. Julie?
Yeah, so Julia mentioned what I was going to mention, which innovation is part of quality improvement, obviously. And all I was going to add is that we are looking towards, and we'll hopefully have it up and running in the new year, and we're doing it in partnership with LPT, is the live QI database, where we will be able to record QI and pull things off the back of it. So we will be able to get reports and information. So there is a plan to be able to put quality improvement, and it's working with the TIE to see how we can also put the innovations perhaps through there. So there is somewhere to record it, hopefully.
Yeah. And actually, we received I think there was a mention of life QI. I think that
live QI.
Live QI. Actually, at the last joint working group meeting, actually. So yeah, that sounds very exciting, because that, you know, anything that helps us with that, and much as you described, David, the Manchester University example, all these things are helpful, aren't they, in capturing things in a methodical way, really, so that we don't lose the brilliant examples that we've got. Thank you, that's great. One little question from me. Under building a sustainable organisation, there's a sort of a reference to our comparator to other systems compared to Northamptonshire, about the sort of different expenditure on community and acute care. And I just wondered, perhaps Paul and other colleagues, really, other exec colleagues, whether there's anything we're able to do with that, in terms, because I'm sure actually it needs to be part of the sort of medium-term financial plan and our discussions and influence that we have with the ICB. Paul, are you happy to comment on that?
Yeah, just very briefly, I think various execs have raised that with their counterparts at the ICB. We had a planning event just last Monday, I think, with colleagues across the entire system, and actually it was referenced there, Krishni, as a fact. It's in many ways across different systems, the way that we spend our money has evolved rather than sort of decided. So I think that definitely is part of the future about where we spend our money. It's a legacy, I understand, of how Northamptonshire has relied on independent sector acute work in a way that not all systems have or have the ability to. So it's a bit of a quirk of history, but definitely is on the radar of ICB colleagues about where we spend our money in the future.
Great. Thank you very much. David, was there anything you wanted to add to that?
So just to say thank you very much. I think that feedback is really useful. It's coincidence on timing, but as an exec team, we are together on Monday, and part of that time we'll be looking at the strategy for next year and the ways of feeding things through. So all of your comments are fine. And one of the challenges is for the NHS all the time is to make sure we're not the best kept secret. We have a habit of doing those things, so it's a reminder for us to capture and share what we're doing. So thank you all for the feedback. Great, thank you, David. So I think at this stage you just wanted us to note that update, and clearly, as you've highlighted it, there's sort of some ongoing thinking about how to present this in the future, and I think it's welcome that the links, obviously, that we've now made to our risks more explicitly as well. So all of that is part of that development, I think. So that's great. Thank you. Okay. So we're noting that progress, and we move on to the next paper, which is paper I, which is the estate strategy, Paul.
Yeah, thank you, Krishni. So I'll take the strategy as read and just reference back to the summary paper. Colleagues will remember that we'd engaged an external company called Arcus to do this piece of work with us. Primarily, they spend a lot of time writing and helping public sector organisations write their estate strategy. And the capacity that's brought was essential really for us getting that the estate's 5-year plan here today. What it tends to set out is the position of NHFT's estate and the infrastructure and how that obviously is an enabler for delivering clinical services. It also is a precursor to ICB plans as well. It makes reference to one public estate and things like that, but actually all ICBs will need to develop an estates plan. We're in the process of doing that. The good news from an NHFT perspective is that we've already done all of the work that has got us to this point, which will contribute to the system plans as well. So that we're quite happy about, because there's no additional work for us. It's also, I should remind colleagues that we've held over sort of the summer months a number of workshops with staff, both clinical and operational, across NHFT to kind of work out where services are, what future plans are, and to see how we can get there. There's a whole bunch of... My dog doesn't like the postman. There's a whole key number of things which are in the summary paper, and obviously they've featured then in how we make our statements within the 5-year plan itself. And just one final point, Krishna, before I open up to questions, is a reminder that behind this 5-year plan, we will have an annual estates plan. We'll develop that through the new calendar year, so that it's in place before start of the new financial year. And essentially what that will do is, based on capital allocation that we've got, we'll set out the priorities that we've all agreed. It will come back through board for ratification, and that we will then keep an update and monitor that through probably transformation committee, as well as through performance committee, so that we can keep an eye on how we're delivering against the priorities within that annual plan. And those annual plans will give us the agility that we'll need as we go through the medium term to respond to service changes and bumps in the road, inevitably. So happy to commend the estate's 5-year plan to the board.
Thank you, Paul. Sakib?
Yeah, really useful paper, and it was quite a long paper, but there was a lot of useful information in it. A question I had was on asbestos. It's mentioned in a couple. So I just wanted to know. Obviously, I guess it's being kept on regularly being reviewed, etc. But if under the backdrop of financial constraints, how we make sure that we regularly review where that is, whether it's a C or D rating.
Yeah, I think we're actually in a pretty good position, Sakib, from an NHFT point of view. Not all trusts that I can talk about with bitter experience are in our position. So we've got a fairly modern estate. So actually, asbestos is less of an issue for us than it might be for others. We do the regular reviews as we've talked about. But actually, financial constraints will never be a problem in dealing with asbestos. It's a health and safety issue, and we'll always respond to it in that way. And that's why the annual plan that I was referring to will always need to be updated and changed to reflect those sorts of priorities. And again, at least it will give all colleagues sight of how we are changing those priorities, and whether that's asbestos or any other safety issue.
Thank you. So, Paul, I think what you're saying is there'll need to be a reactive element to things like that will emerge.
Always will be, right now. Yeah.
You did.
Thanks, Krishni. Paul, thanks for the report. I just really wanted to give a little bit more context as to what was discussed at Performance Committee, because this was discussed quite at length at Performance Committee. And the two things I just wanted to raise was really a recognition that the estates plan is following service demands, not the other way round, which can potentially be the case in certain other organisations. So that was really recognised by the committee. And secondly is that there was challenge from the committee too, not just recognition, and that was around decarbonisation and sustainability. And it was discussed that was something that will be addressed in the annual plans going forward, that will be reviewed by Performance Committee. I just wanted to add that. Thank you.
Thank you. You did really helpful. Thank you. Robin.
I was going to say much the same thing, really. This was looked at in some detail at Performance, and so it's pleasing to see a slightly revised version come up today. This is so important, this strategy, and really, really valuable. I just wanted to say how important that is because of the linkage that it makes to quality, a bit like Judith has just said. A good estate means a good service for our patients. So I think very well done to all who've produced this. And the contractors that we employed have clearly done their job very, very well. Thank you.
Thank you, Robin. So really, really good to hear at the board that the kind of conversation and the response to that took place from Performance Committee, and the amendments clearly that have been incorporated. Scott, please.
Thank you, Kirshni. Just again, following on to some degree from conversation at Performance Committee. Paul, a couple of observations, I think, and then a question, if that's okay. So first of all, in terms of sources of funding, there's no reference at all to private sector in any of the funding sources. I'm not suggesting that we seek to swim against the tide and consider doing something like PFI. I'm not suggesting that for a second, but there are many trusts up and down the country, including the one that I work at in my substantive role, that are making great strides as a result of the utilisation of private sector partnerships and funding to help them advance their estate. So it feels like a miss to me in the report, Paul, not to even be considering it. Right? So just as I say, an observation. Secondly, I think we'll need to have growing cognizance and reference to the balance sheet impact of the changes that we make to our estate as we go forward. Sorry, I know that's a bit of a dry financial technical point, but it will absolutely affect our financial performance as we go forward if we're not taking that into account and reflecting the Performance Committee discussions here into board. I think that's going to be very necessary for us to think about, what are we doing, and is it adding to the balance sheet impact of our estate as we go forward, or are we doing it in a perhaps more elegant fashion? Final comment would be about disposal options. I'd just be interested to understand You know, just how mature are the disposal options, and should we anticipate probably not a current year, but perhaps a next year impact on, you know, our financial bottom line as we start to consider the expansion of things like recovery independence beds and stuff like that. So those were the two observations and the one question, Paul. So if you wouldn't mind coming back on that would be
I'm
great.
sure Paul would welcome commenting on a dry financial technical comment. Or...
Well, to be honest, Christian,
as I keep trying to tell everybody, IFRS 9 and IFRS 16 is really sexy, Christian. It's very important.
While I won't comment on that bit, Christian, if you can't make the dry financial comments to the Chief Finance Officer, I think we need to go on a different call. I think in reverse order, Scott, I think the disposals one, absolutely, we need to make use of that. I think it's difficult when we've got clinical services actually delivering services from within buildings, but actually in terms of how we develop our approach, both as an organisation and as a system to responding to health inequalities, moving where our clinical services are delivered from will be a key feature of future iterations of this plan. And as we know, my predecessor has sat here before and talked about a specific disposal, which is still yet to conclude on the basis of some of the complexities that you get into. So I agree, Scott, our ambition will be around delivering disposals because of the other factors that you referenced, which is the future impacts on balance sheets, and IFRS 16, as you know, Scott, is a sort of hot topic at the moment in terms of when impacts are due or not. And actually, in my mind, the fewer properties that we have, that's one way of minimising it. If we can dispose of properties that the organisation owns, we also have the benefit of reducing our revenue impact, but also bringing in capital receipt, which would be incredibly valuable given the sort of constraints on national capital at the moment as well, which also then speaks to your first point around private sector monies. The 5-year plan is silent on it on the basis that actually within the mental health sector, we're finding it really difficult to replicate what is happening in the acute sector. And again, you know this better than I, Scott. So, but it really features around how acute trusts can use the footfall through emergency departments to everybody's benefit, and that is a real benefit that we don't have within our inpatient units in the same way. We don't have the same volumes, we don't have the same turnover, etc., etc. But absolutely a feature of some of the work that I'm looking at and David's assisting on is how we affect that in the future. So local councils is the obvious sort of place to look. However, we know that financially local authorities are not in a particularly great place and they might not be able to help us. But thinking further afield, the universities might be a place that we can sort of affect future plans. So it's silent on it, but that's because we don't quite know how to describe our ambition, given the fact that it was a very grey area at this point in time.
Thank you, Paul. Tim?
Yeah, so I really like the fact that the report follows our main strategy. So the vision strategy leads and then the estate strategy follows. Where I found this really difficult was the further out we got, the more the actions felt less strategic. And in fact, to a point where if somebody said to me, what does the estate look like in 2028 and what is our vision for that estate? I couldn't tell you because it just started, particularly the longer term element of it was very nebulous. And I would like us to have a North Star that we're trying to aim for, and really a strategic document should have that. And it felt like this didn't conclude there. It felt like the first year plan is set and very firm. And after that, we've got some ideas. And I think we should have a stronger point of view in the estate strategy because we've got a clear view on our clinical strategy. Sorry, I thought I didn't want to be last with the challenge as well. It's a bit awkward.
Actually, Tim, I think it's really helpful in two senses. I think the key themes that came out were around the fact that We've got teams that need more space because things have because services have grown in an unplanned way since the start of the pandemic, which I was thinking just this morning, it's nearly sort of it's nearly 4 years since that began. So actually, what we've struggled to articulate, Tim, and I think is what is coming out in what you're saying, is actually we know what we need to do over the next year or two, but actually beyond that, how do our services and what do they look like going forward? So actually, I think I'm kind of reassured in a sense in terms of your challenge. What I think we need to do, though, in response to that, is to come back with a refresh of this in the not too distant future, and so not 5 years' time, and probably within 2, to bring back and start to answer your question. I think we'll have a firmer idea about where our services are. I think our services will have a better idea about how we're going to try and work in local communities to affect health inequalities. I think it will also mean that we will have a clearer plan about those buildings that we need to come out of and areas that we need to go into. And I think we can be much more concrete about that. So there's a degree here, Tim, which is there's a holding pattern to some of this while we do that work and whilst we get back to that new normal, which kind of sounds counterintuitive sort of this far after the pandemic. But I think that's the reality on the ground, is that people are still reassessing what those needs are. So I think, Krishni, it would be incumbent anyway of us to sort of come back with a refresh of a 5-year plan. But Andy McLester, who's been key in this, and it was nice to hear Robin talk about contractors that we've engaged. Actually, Andy deserves a lot of credit in steering Arcus to get to the right point. But as part of that, Andy and I are already talking, preempting approval here about how we bring back something, the next iteration of it within the next couple of years. So I would have thought somewhere in the next 18 months we can do that.
Thank you. And I think it, that's reflected in it, isn't it, Paul, that there's actually quite a lot of work to be done to get that greater clarity. I mean, that I think is almost some of, so I think it's a fair, I think Paul's saying it's a fair challenge, Tim, is just the reality of needing to do more scoping and understand more of the need, I think is part of it. I think perhaps one other thing, Paul, that, and genuinely don't know whether there is any value in this, but I suppose the more remote and digital solutions come into play, the less estate is the answer to the problem. So there's a bit of me that was just sort of thinking, how do we weave that into it? And it's difficult, as you say, right now it's hard to predict that. And I suppose linked to that, there was just a bit of me saying, well, is there anything else we need to be thinking about with LPT? And I'm not for a minute saying that, we'll be sharing buildings and delivering services, jointly from the same building. But remote offerings might be, if remote offerings are part of the solution, then location may be less important. I suppose that's where it's just an observation rather than, which I'm sure you'll recognise. So do you want to comment on that at all? Because it is a joint priority for us, isn't it?
Yeah, absolutely. And I think you're right about the digital position as well. And I think you're absolutely right. There are some cohorts of patients or some communities that will really benefit from that. There's some that clearly a physical presence is the right way to go, and I think those two go hand in hand, which also speaks to the point about us trying to be ambitious about reducing the number of buildings that we're occupying in any which way. So I think actually the plans that that vision is complementary of where LPT, in my view, need to get to as well. So I think that's absolutely right. The more work that the two digital teams do across the two organisations will help us think about that. We're also bringing conversations much closer together between estates and the digital teams as well, so that we can absolutely do that. But yeah, and as Scott has already alluded to, you know, the investment in digital is in the long run a lot cheaper than buying and maintaining buildings.
Thank you, Paul. I think that was really helpful, and thank you to the performance committee as well for kind of scrutinising an earlier version, and Judith and Robin helpfully sharing their sort of reflections from that. What I probably, well, I mean, we're obviously asked to approve the estate strategy, which I think we should do, because clearly it's at a point in time, but recognising what Tim said, and what Paul's response, we are looking for it to come back perhaps in 18 months' time. I don't know quite, Richard, how we're going to capture that in our action points, but we can plan that in our forward plan, perhaps, can't we, for next year's forward plan for the board, and look to incorporate it into an appropriate point, Paul, that we can agree in terms of an update. But in the meantime, thank you for all the work that's been done. Clearly a lot of effort has gone into that, and it's been well received, so thank you. And if colleagues are content, we'll approve the strategy. Okay, thank you. Finally, in this section then, we've got the next paper is the East Midlands Alliance Common Board paper. So bring David in for this, but this will be the paper that's gone to all of the partners, won't it, David, for the same ask, really. So over to you.
Lovely, thank you. Yeah, that's absolutely correct. So it's gone to the 6 partners of the East Midlands Mental Health, Autism, Learning Disability Alliance. So that's 5 NHS providers across the East Midlands and St Andrews Healthcare. So it brings together a summary. We've got the actions that are listed in there. There's a couple of quick bits that I just thought I'd draw out. So I wanted to really reinforce, actually, we've had a really useful board meeting. Chairs and chief execs from across the trust have been involved. And we've got here today a vision, values, objectives that everybody is proposing to take forward as an East Midlands Alliance. So that's there. There are a couple of, well, the actions and the ways in there. I wanted to just say to everybody, in the Common Board paper, it talks about a date in March and a hold the date. And I just wanted to say to everybody, that's not a hold the date for every board member of every single trust. It's a notification for the trust. There'll be an event happening on that day. So if you were sitting there thinking you had an additional date in your diary, you don't. We'll work that through from an executive level and attendance. The only bit I just wanted to draw out, because I thought it was really helpful to just help understand a bit more about the Alliance, the work and the range of work going on, is page 169 of our packs, and just in this board paper, the Common Board paper under the Reducing Inequalities work, it's also just flagging that the delivery of all of the strategic objectives are going to be picked up by different professional networks. And I thought that was a useful reminder about the breadth of work that's going on in the East Midlands Alliance. So just to help draw that out, quality improvement and productivity is going to be taken forward by the Medical and Nurse Director Forums, and that will also include the Enabling Safe Care and the Patient Safety Programme. Reducing inequalities, again, will be picked up by Medical and Nurse Directors, with developing our workforce being picked up by the HR Director Forum and the Improving Population Health by the Strategy Director Forum. So I thought it was worth bringing out because it kind of shows the breadth of the work that's going on. It also helps reinforce there's a whole range of different professional networks and people coming together. So often, while it's me presenting an update on this report, sometimes that means we can miss the fact that there are many others involved from across the organisation. So I thought that was just a useful summary of where we are. So happy to pick up any other queries or questions.
Thank you, David. Any other thoughts? Julia?
Thanks, Krishni. It's not a question, just a comment, David, just to say what a fantastic piece of work to bring together everything that's going on. That's not easy, in a very succinct way. And actually, I feel much more confident that I could describe a lot of the activities that are happening, which is really important for us to know as we look at other items on board agendas, etc., and look at the impact for our communities. So absolutely brilliant document. brought together so many important pieces of work, and what depth to all of this. And I'm sure we shall hear about some of the work within the professional networks through other fora, but just to say a huge thank you for this, because it's really important. It's very easily explained, and it's really, really important piece of information. Thank you.
Thank you, Julia. Robin?
Yeah, again, very helpful and very useful report, but I think it's not just what it says specifically, but the detail of what it's saying in terms of the ability to provide services on a regional or indeed a cross-county footprint to address lower level of demand for particular issues. As I said before, I used to be the National Commissioner of all gambling services in the UK, and the way we were doing that was by a regional commissioning of services because of the lack of money and the lack of demand. And this is just an illustration of doing that within the East Midlands area that we are concerned with. So it's really useful to use that as an example just of how valuable it is to be part of these kind of partnerships for low demand areas. That said, the scale of demand for gambling is much higher than it was and is according to all the data. However, just a last point on gambling, there is a new national levy on the gambling industry to fund particularly NHS treatment for gambling. So it's one we need to perhaps think about strategically as an opportunity.
Thank you, Robin. Angela?
Yeah, thanks, Krishni. I think just to highlight a few things, I think it is a really significant step that as an alliance we are creating a vision and values that we're all going to sign up to, and also a communication launch, which I think is, reflects the maturing of the alliance and the relationships and its purpose. So I'm really pleased about that personally. I think the other thing to say is that there is no doubt that through this work we are attracting more resources, which is evident in the paper, and in particular on the patient safety programme. I think it's clear that without the alliance we wouldn't be having that funding for the continuation work on that, which is pretty important. And then I think again just the final point is that we are now seeing across the acute sector in the East Midlands, they are looking to come together in a similar way, which is following some of the work that mental health has led on, which again I think is encouraging that there is again that being adapted and adopted by others in different sectors. Thanks, Krishni.
Thank you, Angela. And David, do you want to come in just on your point about the income gains, but also Robin's comment about potential additional funding for gambling support or support for people with gambling difficulties?
So, talking with one voice across the East Midlands for mental health, learning disability and autism makes it easy to have a conversation with NHS England once, with Health Education England once. And this they find incredibly easy, which means that they're sitting down and saying, how can we invest? How can we work with you? And if you look at the kind of the programmes and the work that we've been doing, there's an awful lot of money that has been invested in the East Midlands through being able to speak to us with one voice. If we hadn't been able to speak to them within one voice, we'd have been at best competing against each other to find who could write the best proposal to bring that money into one of the systems. Doing it this way, we're able to say, right, how do we make it work? How do we challenge it forward? So I think it does add some value. On gambling, absolutely. I mean, one of the key bits going forward is picking up the gambling programme, Gambling Harms, and understanding some stuff. I know that our psychology team are really interested in how we support it, how we move it coming forward. There is one of the organisations, and their name's just gone. One of the other trusts is leading on it, and their name's just gone out of my head. But feeding that in and building in what we expect to be a growing issue is incredibly important.
Thank you very much, David. So we're asked to review and approve the vision, values, purpose and strategic objectives because it felt important, I think, for all of us to record our support for that so that we have a common view of what this Alliance is striving to achieve. And so can I just invite people's support for that, everyone content, that it's a helpful summary of what we're aiming for. I think the rest of the report is obviously a broader update for us to note, and with the potential that we might be invited to an event, some of us anyway, to an event on the 12th of March. So we'll wait with bated breath, David, on that. On that note, I'm going to suggest that we take, I will, rather than run on to the next item, I'm going to suggest we take a short break and come back. Welcome back, everybody. Make it 11:35, so let's kick off again. We start with our integrated performance section now, and over to Judith for our assurance report from the performance committee, please. Thank you.
Thank you, Krishni. I will take the report as read. There are a couple of points I would like to, however, raise verbally. The first thing is the point of the approve point in regards to the Performance Committee's terms of reference. From a national point of view, we are required to have had a CIO or CDIO added to a level 1 committee, so that is the amendment. However, the positives of re-reviewing our terms of reference is that I identified a little anomaly in the wording under purpose, which refers to organisational development, and the key objectives, which then refers to business development. So I would propose just to close that loop and have the reference to business development, because organisational development as such would probably fall under Integrated Assurance Committee. So that's the only additional amendment I would propose if for approval. The other points in relation to advice, the 2 points that arose under advice was obviously the finance update, which we were looking at month six. It's now been completely overtaken, but not only by month 7, but also by what has been happening nationally at ICB level. So the reason why that's under advice is in the report, and it's the same as it has been for the last few months. And with regards to the system planning, the note really there was that it's very, very good news that we are planning slightly ahead of ourselves. However, it would be really beneficial to have a clinical presence at these planning meetings, which I now understand is the case, or may not be the case. Paul is sort of making a face there, so I presume he'll be able to update. The rest of the report under Assure is something that we are covering off in the board today, so I will not address those except for the Transformation Committee report and the Collaborative and Commissioning Committee report, which have been 2 reports where I've certainly felt it was difficult for me to understand what assurance to gain from the reports as they stood. And I'm happy to report that both those committees will now use the AAA report style, which will be a really useful addition to the our assurance framework for Performance Committee. And finally, I'd just really like to celebrate some outstanding, and that was the report that we received from the Pathway 2 update, and apologies for my typo errors in the report. The entire update was so full of enthusiasm and professionalism, attempting to do something really quite complex, a really large major project, and the method of application and approaching it was just phenomenal. So really celebrate the outstanding for that, and I will leave it at that, but happy to answer any questions.
Thank you, Judith. And did you want Paul to respond to the other point regarding clinical input, Paul?
If he has anything, yes, please.
Yeah, I think my grimace, Krishna, was that there was nothing new to add to what Judith was saying in terms of that at this stage.
Thank you.
Okay. Thank you. Okay, good to celebrate the outstanding as ever, and helpful to highlight obviously areas which ongoing work is happening. I thought it was just helpful also to see the improvement noted in mental health out of area performance, because that's been that's a consistent challenge, isn't it? And actually has both patient and financial implications, which are important to recognise. So just wanted to note that. The terms of reference we do need to approve then. So in addition, I think you're saying, in addition to the amendment that's noted in the actual accompanying document, you're just asking us to support the additional change you wanted to highlight in changing organisational development into business development, which is in the purpose section. I think the board would be, I'm sure, happy to approve that. And Richard, if we can retrospectively amend that or note that amendment, I think that'd be helpful. So thank you. I think we've approved that, and thank you for the report, which is noted, Judith. And over to Dave for the integrated organisational report, please.
Thanks, Krishna, and thanks, Judith. So just mindful of time, and there's quite a comprehensive cover sheet, I think, with the papers. So I'll just draw out some key themes. We are continuing, as all organisations in the NHS are, to see increased referral and demand for services, with consequent pressures on waiting lists and times. That has been, I guess, exceptionally compounded by some of the financial context that we're operating in currently. That's a national position. So we have had to step back from some of our transformation work to allow some of that picture to emerge in terms of what our planning and overall deficit and surplus positions might be. So we have since restarted some of that recruitment in September. So I do expect that to have an impact on some of these waiting times in due course as we begin to work through the issues. In terms of turnover, I mean, it's an integrated report, and there'll be integrated input from colleagues, I'm sure, as we move through the detail. We're not seeing kind of major spikes in sickness, thankfully. It seems pretty consistent. We do expect, however, looking at the prevalence data from last year, that weeks 49, 50 and 51 are kind of nationally the spike weeks for flu and COVID and respiratory illnesses. So that's ahead of us, but we've put plans in place with the support from our workforce group on ensuring that we've got incentives in place to ensure colleagues are able to put themselves forward for work over the holiday and sickness season as it happens. Of good news, I think we've launched the patient safety reporting framework earlier this month, in fact, and we are seeing an increase in safety incidents reported, and that's really important for a few reasons. One is it's an indication that people are confident in being able to report those issues, and we're able to put a quality lens on it. But also, you'll note in the NOF, which is our national oversight framework, we are measured against under-reporting on patient safety. So actually having something that is increasing gives us a certain assurance that from a national oversight perspective, we're on that, and we're keeping our focus on those incidents. The Equivia Friends and Family test that replaced Brown Great Care is now beginning to gain traction. So we're seeing an increase in responses, and hopefully it's pretty good feedback in terms of patients' experience. We'll talk a bit more about finance later, but again, just to reassure colleagues, our value programme is on target. So the plan we set out for that is on target to deliver about £15 million worth of additional value this year. And we've got plans in place for Q4 and emerging plans with the system into 24-25 over the next coming months. But fair to say that will be an increased focus for us as an exec team and for our board and for our colleagues as we begin to look at value across teams, across communities, across everything we do, because that will be the shape of what we have to do over the coming year and months. And then just to finish off on out of areas, as you say, Krishni, really good results. We have currently no out of area patients at the moment, and that looks to be a trend that may continue. So fingers crossed. Thanks very much.
Thank you, Dave. Julia?
Thanks, Krishni. Thanks, Dave. Just to give a little bit of extra triangulation to those that don't know what's seen at other committees. So you mentioned there, Dave, around patient safety incidents and the new framework, etc. And through the safety committee and then through quality and safety committee, we get a really good opportunity to look at the detail and the trends and the learning. So just to support that. And then the IQVIA system that you mentioned around patient feedback, you'll see very shortly in the quality and safety update, we had a deep dive on that at quality and safety, which I'll come back to briefly in a few moments, but just to sort of show people the triangulation that happens, and a lot of the detail in this report is actually seen at other committees, and it's all brought together through this report, which absolutely commend it. It's grown, it's matured, it's developed, and it gives us a much better holistic look at what's going on and the impact for staff and patients. So thanks, just those extra points.
Thank you, Julia. Yes, thank you, Julia. It does continue to develop, doesn't it? Which is really great to see, and the information is so presented in a very easily digestible form, particularly like the agency information that's presented. I couldn't remember whether I'd seen that previously, but I certainly found the way that the framework, the sort of different elements were broken down really helpful. Is there anything, I mean, clearly agency remained a sort of red alert on, and we did tell our governors, I think we shared that with our governors, didn't we, Richard, at a previous point in time. So I just wondered if there's any more we want to say about where we are. I know that it's also linked to the finance conversation later, but I don't know whether Dave, there's anything you want to particularly say, or Chris, actually, about the agency position at the moment, because it's an ongoing challenge and one that I know NHSE also recognise. Chris, do you want to come in on that?
Yeah, just to say, in the month, the last month, October, our agency spend reduced. It is a big focus. We've talked extensively with the Integrated Assurance Committee about the deep dives we do and the workforce efficiency panel that considers both the vacancies, but also considers any requests for long-term agency. This will be even more of a focus as we move forward within the financial plan Paul presented. But there are various initiatives we're taking, for example, seeing if we can move staff from agency to bank, and we have had a couple of successes there recently, and that's more of a dialogue. We've got high levels of approval for agency, so I think the board, I would suggest to the board, it can be assured this is a really hot area for scrutiny, but we are seeing progress as well. But again, Paul may want to comment because it's a big factor in what we're doing. And we are, we've got to be conscious of what we need to do, but we are comparing favourable to colleagues in the system who seem to be even more challenged.
Chris, thank you. Paul, do you want to comment or pick that up later?
Only to echo really what Chris has said. I think I continually remind colleagues that all of that procedural checks and scrutiny that Chris has outlined actually is still across the region, not universally in all trusts. And therefore, while there's more that we can do to reduce how much we're spending, we are tracking in the right direction, and it has been recognised by system and regional colleagues in that sense. So, yes, I can only echo what Chris has said.
Thank you, Paul. Dave?
Just to round off on that, Krishna, I mean, I guess the agency piece is a workforce issue and a quality issue in terms of not to suggest that our agency staff deliver poor quality care, but we know that our substantive and bank staff deliver care that is absolutely consistent with our values and how we want our patients to be treated. So it is about value, and it is about value for patients, values for teams, because they have a consistent team presence. They don't have vacancies which they need to fill all the time, so they can be coherent about how they deliver care. So it's social value because we look to give employment to our local residents. It's value across the spectrum. So just to re-emphasize that really when we look at these kind of thematics.
Yeah, And hence it's very much an integrated performance issue, isn't it? Because it cuts across so many aspects of what we're looking at. So really important point on which to end this item. Thank you, Dave. It's a great report and really helpful to have a couple of particular areas of focus for discussion. And the board is asked to note the report at this stage. Thank you. So we move on to the quality section of our agenda today. And first and foremost, Julia, over to you for your report from Quality and Safety Committees.
Thanks, Krishni. So we'll again take this as read, just a couple of areas to highlight. So we're recommending 2 items for approval by the board today. Details are in the appendices. The first one's the National Patient Safety Incident Response Plan, and you've heard that mentioned a few times in relation to the strategy, and really important plan. It's been through both the Safety Committee and Quality and Safety Committee, and we're recommending it for approval by board today. And the other one is the NHS Sexual Safety Charter, and we bring you the commitment of the organisation and an implementation plan. Just want to reiterate why this is so important. We're committing to a zero tolerance approach to any unwanted, inappropriate or harmful sexual behaviours towards our workforce. And that's really important, and we wanted to highlight that today. And the implementation plan is going to be key to how we uphold that commitment, but we felt it was important to bring it to the board for our commitment today. So that's those 2 items. A couple of areas in alert: the continued alert around children's ADHD and autistic spectrum disorder service. And just to highlight that we're going to have a deep dive into the current mitigations and future plans for the service at the next committee in December. And then the second one is around quality summit process that happened around some of our secured services. And just to commend that process, very open, very transparent, and the assurance, quite substantial assurance we took from the detailed oversight by the exec team, and we'll keep an eye on the implementation plans for that service. Already talked about in the advice section the deep dive around the IQVIA patient feedback session, a system rather, and we looked at some gaps in assurance, and again we'll keep a monitoring watch on how that's rolled out and implemented. 2 quick things in the Assure section. They were board actions from previous meetings. The first one was around the NHFT response to the CQC monitoring the Mental Health Act report. Really important learning from that, which the committee took full assurance from. So we're recommending that that's closed, and that was an action, as I say, from board previously. And the second action from board was to look at the learning from the critical incident back in January this year around system capacity for patients. And we brought that learning back here before, but we've had an update and we now feel that's time to close that action on behalf of the board. And just to celebrate outstanding, as the other committees, some amazing pieces of outstanding work, especially great Allied Health Professionals Conference on National Allied Health Professionals Day. Some great work being undertaken, and I'm happy to take any questions or comments on the report.
Thank you, Julia. Judith first, please.
Thanks, Krishni. Julia, thanks for the report. I've got 2 questions, and I've got to proceed them both with an apology because I'm going to throw a couple of things at you. I'm not sure if you're the person to answer the questions, though. So firstly, in relation to the paper, Appendix A, the Patient Safety Incident Response Framework, I mean, it's a really, really detailed paper. But what I don't quite understand from the plan is clearly the closing of the SIs had a bit of a bottleneck around the investigators, so that sort of potentially slowed things down. Under this new system, is it expected that there might be similar bottlenecks, or have the bottlenecks moved somewhere else, is really what my question is, because there is a lot of reference to improvement plans, and that potentially can slow things down. So that's my first question. The second question I've got is totally different, and it's to do with my earlier comment about not really seeing the next layer down risks. And this was, you mentioned adult ADHD medicine shortages nationally. I mean, clearly there's an impact on patients and there's going to be an impact on staff if there isn't already. We did receive a flash report, and I think that was about a month ago. I was wondering if the QNS had any update to give the board a little bit more of an understanding of where we are. And are adult ADHD or child ADHD, are the patients getting, the service users, is it more acuity? Is it, I just don't know how it impacts, because some of the services I have visited recently, in fact, have a plan for this, and I don't know if that was something that QNS discussed. Thank you.
Thanks, Judith. Krishni, shall I come back in on just a couple of those? The second one first, I can answer. We haven't actually had a committee since the board flash report. We've got that in a couple of weeks' time, so I may default to Anne or David on that in a second. Oh, Anne's come in. Should we take that point first?
Yeah, Anne, do you want to come in on that?
Yes, we've had, I don't know, I put my hand up because Ito's not here and he's been chairing some clinical summits on it, but he's senates on it, sorry, but he's away. So Linda, please join me if there's anything, or Julia extra. So since we've had that, we've had more circulation of medications through the system, and I'm not hearing at this stage of any increased difficulty regarding medications. We're keeping a close eye of it in the summits, in the Senate, sorry, to make sure that because obviously when you have something stopped for a period of time, then you get a flow through, you can get some bottlenecks. I'm not hearing that from services particularly, but we can definitely find out some more information from the next QNS. Julia, I'm not sure if you know more.
Thank you. So I suggest that actually we'll sort of defer on the basis of that update, and it sounds sensible to wait until the next QNS has the opportunity to review that, if that's all right, Julia, and then perhaps provide some feedback further, unless of course there's any urgent development in the meantime, in which case a flash report, a further flash report may be needed, but we'll perhaps delegate that back to you for you to explore and then feed back to us at the next meeting, if that's okay. On Judith's other point, are you able to say any further on that?
I can give you an initial response, and then I don't know if either Linda or anybody else wants to come in. So Judith, you're right, there's been bottlenecks. We've been monitoring the impact of that around some of the serious incident investigations and thematic reviews. The new framework, as I understand it, actually gives us, under a broad term of a patient safety learning review, gives us a suite of options of ways to investigate and ways to look at an incident in a much broader terms. And so it doesn't shoehorn us into the very strict criteria around serious incidents which we have at the moment. And it does open us up to much more appropriate forms of investigation. So I'll bring Julie in, but I took the assurance from when we've been talking about the new framework that it actually gives us much more flexibility to look at different types of incidents, so we really get to the learning quickly without being, I like the phrase, shoehorned into a particular process. And of course the safety strategy which this comes under has involved patients. We've got new patient safety partners just recently appointed, so there will be a huge voice from families, patients, etc. And the last thing I would just say is that the recent patient safety strategy day that we had, which had about 100 attendees across the organisation and external partners, we talked in detail, we heard in detail about the impact on families of investigations and how we handle them. And I'm confident that this will bring us a different way of looking at incidents to get to that learning, and that the patient voice and the community's voice will be absolutely centre and forefront of any investigation. I don't know, Julie, whether there's anything else you can add for me.
I mean, I wasn't going to come in on that. I was going to come in on something else. And Linda's put her hand up, so I'll leave Linda to talk about the patient safety framework, and then I'll come in on the other thing I was going to come in on afterwards, if I may, Krishni.
Yeah, do. Linda, do you want to just comment on that other point then, if there's anything you want to add to Julia's assurance?
Yeah, so thank you for that question, Judith. I just wanted to add on to what Julia has mentioned. So as part of us moving to the Patient Safety Incident Response Framework, PSIF, we've had opportunity to review our current process in the allocation of our investigations. And because there's an over-reliance on the clinical investigations team, who also complete investigations for our complaints, it then means that at several occasions, that capacity has been very limited. And then when these investigations have been allocated to practitioners, they are doing this on top of the day job. And unfortunately, lands it that it goes to the same people because those same people are the ones with the skills. So we're broadening out the training. Our specialist team will focus on our priority areas. And actually, the structure we then have will land itself to a situation where we spend more time engaging with families, patients, and also a focus on learning rather than us just doing an investigation because we have to do it. So that will actually reduce the numbers that we have to do insofar as investigation, but we then spend more time doing something more meaningful because we've had quite a number of investigations where there's actually no actions for learning to take forward. So we don't want to continue that process. So this is a real good opportunity. Plus the fact that we recognize there's been changes in our staffing. There's other people who've since moved into more senior roles. We haven't really paused and stopped to give them the training to be able to investigate. So instead of just rushing and giving people training using the previous method, which was our root cause analysis, it's got to be aligned to PSIF. So that's what we'll be taking forward in the new year, which will then mean we will not see the bottlenecks that we previously had. Thank you.
I think that's a pretty comprehensive answer between Julia and Linda there, Judith. So that I hope that's helpful. Julie, you wanted to come in on a different point.
Yes, I wanted to come in on the quality summits that have been done around the prisons, and will continue to be done because I've just recently done the Peterborough one, and I just wanted to raise the context that the prison it's all around at the moment. So the context around prisons, we've talked previously about Operation Safeguards, where you know, His Majesty's Inspectorate of Prisons have implemented Operation Safeguards because of the pressure on prisons around the roll call, the amount of people that are in prisons. I think they're operating about 99% cell occupancy at the moment, so that is having an increased pressure on our workforce. I think we also need to think about when we look at our prisons is the environments as well. They do have an impact, and we've talked about environments before. Some of our prisons are Victorian environments where we're providing healthcare. Some of them are newer. We've got a very varied environment that we deliver healthcare in. So I just really wanted to add the context around the quality summits because I think it's important as we move forward, looking at the prisons.
Thank you, Julie. And clearly that's an ongoing piece of work, isn't it, that you're describing? Yeah. So thank you for that. And no doubt we'll be getting further updates on sort of findings of these summits as you go through the process. So thank you. That was a really comprehensive report from the Quality and Safety Committee, and the board is asked to approve the Patient Safety Incident Response Plan for the organisation, noting the potential benefit of sort of, you know, reducing some of the backlogs and challenges that we've had previously in the way that the investigations have needed to be conducted, and the opportunities for improvement for learning and for patients and their families. And we're also asked to endorse and support the implementation of the NHS Sexual Safety Charter, which I'm sure colleagues would be very willing to do. So thank you very much, Julia. Right, we move on then to the quality framework, which is paper N, and that's over to you, Julie.
Thank you, Krishni. I'm not going to go through this framework in detail. I know a previous draft version was shared with Q&S members for their comments, and it's been shared across the organisation, and we've had some really good feedback on it actually, and we've responded for those comments. This is the final draft version. It is a revised version, so we've had a quality framework in the trust for many years.
This framework supports the Q element of Digby Q, and really we've developed it further, so it has got added sections in this year as we've developed as an organisation. So we've added in quality surveillance, continuous quality improvement, we've updated the quality governance section, and we've also added a section on other factors that support quality. So I'm bringing it here for board approval.
Thank you very much, Julie. I think the only thing I just wanted to make sure I've understood correctly is that we're introducing in effect an additional group of quality and assurance, safety assurance.
Yes, so we are bringing together quality and safety. We are aware that the Quality Forum takes too much, and it's historically we've had challenges with it. So actually what we want to do is we look at the committee memberships, terms of reference, but bring quality and safety together in one place, and we can look at the assurance there, and it's a place to look at the triangulation information as well, because we've put in place a triangulation structure for our quality information, which is led by our quality head of quality surveillance, and actually that needs to come into that committee as well. So once this framework is approved, we'll then start working on the terms of reference and realigning the groups.
And that will then provide the additional, the sort of more streamlined assurance then to quality and safety as a board level committee. Helpful. Thank you, Julia.
Thanks, Krishni. Thanks, Julie. It's just worth noting that I think due to timing, we hadn't reviewed it as a collective committee together and been able to comment and shape and inform, but we absolutely welcomed, thank you, Julie, the opportunity to comment individually. So I think it will be, hopefully, it may be something that evolves and grows anyway, because we haven't had a collective opportunity to sort of discuss things and take things together, but definitely had the opportunity individually to comment and shape it, so thank you.
It's clearly been through a review process, so perhaps the board could support the direction of travel, and then just ask the quality committee to just satisfy itself that all of those comments and feedback have been collated together. Does that sound like a reasonable, does that sound reasonable from your perspective? So definitely helpful, I think, to have a document that pulls everything together, Julie, as we've had it, as you say, in the past. So it's a good direction of travel, but we'll just ask Quality and Safety Committee just to pull it together and make sure everything is consolidated. Is that okay, Julie?
Yes.
Great. Thank you. Then we move on to the board, the NHS Impact Board Improvement and Self-Assessment, which is paper O, please.
Thank you, Krishni. So I think the S-bar gives a bit of background to what NHS Impact is. It's part of our quality, it is in the quality framework. The 5 practices are part of our quality framework, but Impact actually stands for Improving Patient Care Together, which is what we're here for, isn't it? So actually they suggest that the board, all boards undertake a self-assessment, and it's actually a self-assessment that has been developed by NHS Impact based on the 5 practices. So I bring it here for the board to look at the self-assessment. I have put together an initial self-assessment. I have initially scored it. It has been to Strategic Exec Board, and my colleagues have also commented on it, and some changes have been made. So really, Krishni, I'm not sure how you want to take this forward. If you want me to go through each section, I know time is short, or how you want to do this.
Thank you, Julie. I mean, I think it's a really helpful self-assessment in many ways. Yeah. It's always good to reflect on these things. What's the timescale for submission? Just double check.
Don't need to submit it anymore. Okay. Originally, we did need to submit it.
And that was a couple of months ago, but they changed. So I brought it to the next available board, really.
Okay.
So it's here for board, but as time's short, as I say, we have obviously.
Yeah. So, would colleagues like to comment? I mean, you know, there's some. It's a bit like a well-led self-assessment.
It is,
isn't it?
yes.
There are elements to it. I think it's helpful for the board to actually debate, if you like, because there are some things where I think, oh, you know, do we have evidence that we might actually be a little bit better than we've rated ourselves? There might be other things we want to look at the other way. So. I just think it is quite helpful. It is quite a useful document. So perhaps it's something we should, if there's no great demand for submitting it by a particular timescale, it might be helpful just to come back to it together at a board development workshop. But Angela, take your view on that.
Yeah, no, I think I would agree, Christian. I think it is a tool for us to use, and it's helpful in that regard. It's a little bit like, I think, the freedom to speak up self-assessment. It's better to be having the debate within the board, and I think a development session would be useful on the quality improvement perspective. And also, as you say, Christian, then what's the evidence? Because we might find actually there is different levels that then, you know, obviously take us to different places. So I think that is absolutely what we should be doing, and it should become a dynamic document and tool that we use to understand where we are. Thank you.
Great, thank you. So if colleagues are also supportive of that, Richard, can we build that into our February development session? And as we say, because I think, you know, it's an interesting model, but the challenge, the confirm and challenge between us is actually the process that's quite helpful, isn't it, in determining where we think we collectively sit? Because I would imagine this would be evidence under the well-led, in a well-led inspection. So it's important that we feel a collective ownership of it. So really, I think let's note where we are at the moment with it, and agree that the next step, you know, it's a positive tool, and we'll use it for a further discussion at a future board development session to endorse our final view on it. Thank you very much. Next, we have the Patient Safety and Learning Assurance Report for September and October, which is paper P. So over to you, Linda.
Thank you, Krishna. It is a long report, so I'll take it that colleagues have been able to read the report. Just to add on to what has already been mentioned by Dave when he presented the integrated organizational report, and also Julia's report around the process that we use to triangulate and also pick up on early warning signs that could potentially mitigate and prevent some risks that might be emerging. We provided detail of the top 5 patient safety risks, and we note the increase in reporting, which is actually a positive thing. And this is noted particularly as we move to the learning from patient safety events, which launched in September. So we welcome that increase in reporting. We're still reporting most of our incidents resulting in low or no harm, so 95.9% of our incidents. So that is positive, although we do aspire to have completely no harm incidents. We've provided further information around work that is happening with regards to some of the incidents that we have, particularly around pressure ulcers and the work that we've been doing. I'm pleased to also mention that within our community nursing teams, where we previously reported a backlog in Datix incidents, which was affecting the audits, that backlog has now been cleared. So we are now progressing the work in implementing our audit in a more live and up-to-date situation, and implementing a new tool that we've adapted from another organization. So we will report more on that. We've also reported around self-harm incidents and the categorizing that's been clarified, which is helpful, particularly around when we were seeing the reporting that was being used for CAMS inpatients, which skewed the figures when we were reporting the restraint to feed figures. So some recategorization has been useful in that. What we've also included in this report, which is key for board, is our learning from deaths. So again, we continue to learn from the deaths across the organization and share this information trust-wide, including learning that we take part in with our external partners. We've then mentioned within the report around any unassigned investigations, and certainly there has been a shift, and the situation is a more improved situation to what we previously reported to Trust Board. We continue to monitor this, and it's one of the areas that myself, Chief Operating Officer, have regular catch-ups on. So each week, Anne and myself are touching base on actually what's not allocated. Can we move something to someone else because this one is a priority? And that seems to be working really well. But even when we're working for the allocations, that doesn't stop immediate actions being taken through. So that's the strength of our internal assurance meeting, where that is immediately teased out and the teams start to do that work. We've also provided some information within the report that details all the work that's been done around the patient safety strategy. And a huge thanks to the patient safety team for putting on a very well attended event on the 15th of November, and special mention to members of the board who attended and supported that event. So thank you to everyone for that. So this is the report that we are presenting, and ask that board is assured that we are being open and transparent. We are maintaining a duty of candor, and that we continue to learn from incidents across the organization, teasing out themes so that where possible, we are preventing harm from those who use our services. I'm ready to take any comments or questions. Thank you, Chair.
Thank you, Linda. Thank you. I think Julia and Robin might attended that event, didn't you? I think I seem to recall. So, Julia, please.
Thanks, Christine. Yes, we did. Brilliant event, absolutely brilliant, but focus on patient safety. Just one quick additional piece of assurance in that this report comes to the Patient Safety Committee, which was last week. And we always get opportunities to challenge, question, gain additional assurance, etc., as well as hearing about good practice. So all of these areas have been fully looked at and scrutinised and additional assurance sought. And just to say one really important thing that the Patient Safety Committee does is look at each time a thematic a review of a serious incident, and we look at the detail and the report and the openness and transparent nature of the report, and the involvement of families and patients, etc., really shone through, and comes out with some very significant actions that are taken forward. So it's a really good piece of assurance into the patient safety area from that committee. Thanks.
Thank you, Julia. Robin?
Just to back that up, really, other board members really should take confidence that there is proper assurance of the importance of safety to within the trust, and the real degree of scrutiny and processes that are in place to ensure adequate coverage of this area. The event on the 15th was really brilliant and really impactful, and indeed very moving, because it started with a complaint, really, or rather a problem, and it looked at how it had been addressed and resolved. So I think there's a lot of very impressive work here.
Thank you very much, Robin. Really helpful additional kind of colour around that event and the report and the assurance that's gained at Patient Safety Committee. So thank you, Linda. I think the board note the report and take the assurance that's presented within it. We move on then to paper Q, which is the Monitoring Workforce Safeguards report.
Thank you, Chair. Again, another lengthy report, and take it as read. Just some highlights within this report, particularly around our 6-monthly establishment reviews. So the way that we've conducted them this year was that earlier in the year, we conducted the first 6-monthly establishment reviews, and part of the work that was done there linked into our value program. So we were able to report on that at a previous board meeting. We've commenced the work on the next 6-monthly establishment reviews, which was the data collection, confirm and challenge. However, there was some miscommunication within our team due to the matron for safer staffing leaving last month. So the team were not aware that would be presenting the information. So the information was there, but unfortunately wasn't captured within the report and had not yet gone through our Workforce Safeguards Assurance Board. So our ask is that we can present this to the Integrated Assurance Committee in January, and then we'll bring the information at the next trust board in January. So we've included within the report the risks, and you'll note that the risks now show which risk number they're associated with on the risk register within the directorates, so that there was more linking in with those risks. We provided mitigations. Updates on risks that have previously been reported have been provided within the appendices. I also wanted to just highlight with regards to training. So an area of focus had been our safeguarding training. So we have achieved compliance for our level 3 safeguarding adults training. However, from the report you have currently, which reports level 3 safeguarding children training as at the end of October, this figure will reduce significantly because we've got to add on other clinicians who needed to have completed the training. So at the time of reporting this information, we had not included clinicians, those not specifically working in children's services. So the numbers will decrease, compliance will decrease. These figures are being pulled, I've been told today, yesterday, so the information will be a reduced number, but we have put on the training dates. We have had planning meetings, which have included myself, Chief Operating Officer, Learning and Development colleagues, in order for us to facilitate for staff to then be able to complete this training so that we are compliant with specific areas, particularly those recently inspected by the CQC have been prioritized, and the aim is that they will be compliant by January, with other areas all being compliant by the time we get to the 31st of March. Whilst we're prioritizing areas for training, the training itself is open to all staff who will be due to attend that training. And we're putting on additional dates, have not stepped down the 2 dates that are planned monthly. This will be in addition to those dates that we already have. So we'll continue to monitor this. It will be reported through into our safeguarding group, which reports into the quality forum. This information will then be reviewed through our report to Quality and Safety Committee. But as we report now into the Integrated Assurance Committee, we'll be providing an update again to them next month. So the other areas just to highlight within this report, I certainly didn't want to miss an opportunity to share when we provide our corporate updates on staffing, that one of our internationally educated nurses, Maria Y, who works as a staff nurse at Daintree Hospital, was fortunate to attend the 75th birthday reception for King Charles on the 14th of November at Buckingham Palace, a really, really colorful event which celebrated the contribution of nurses, midwives in the UK. And this was covered by our local media. So we were really pleased that she was able to attend, and absolutely she loved and enjoyed the event. So that was something that's really been very welcome for the team. Angela has already mentioned that again, we were able to get our quality award for our preceptorship. So some really good things that are happening that again motivate our staff. And actually, these are the things that retain our workforce. So we've asked the board to accept this report, recognizing the increased pressures we have in some areas, but we've put in the mitigations with regards to those. I've already mentioned about our 6-monthly establishment reviews, and ask that the board receives this report together with the recommendations we're making. Thank you, Chair.
Thank you, Linda. So we particularly need to note that the 6-month establishment review, the paper from that is going to go to Integrated Assurance. I think that's what we've agreed, isn't it? And Richard, the plan is that that will go in shortly, I'm assuming, for the next meeting. So we'd be looking for assurance back from the committee in due course. And I think other than that, are there any questions or comments? I think helpful to note that there'll be a dip in compliance on safeguarding training, I think is what you're saying, Linda, but there are plans to address that. Anything else that anyone wants to clarify? Okay, thank you. So we note that report, and then finally the complaints report, please, paper R.
Thank you, Krishni. Again, with the complaints report, I will take it that the paper has been read. Just to highlight a few areas in this report. So when we look at the performance around our complaints and also our PALs, as an organization, we're happy to see the increased upward trend in our PALs contacts, because actually the more work we do from that level, it means that we see less of complaints and we can immediately engage people, liaise with them, so that it improves their experience of using our services. So we're really pleased to see that. We're also pleased to note that we're not seeing a marked increase in complaints. Whilst we know that there's further input required to manage these complaints, it's a positive that the teams are actually responding to issues, queries when they are raised in a more timely manner. We are also noting that we've provided some analysis of the information, the data that we have with regards to our complaints, and note that there have been complaints where we've had to renegotiate the dates that we get back to complainants, and that's for a number of reasons, including some situations where further information has come to light, and then that needs to be looked into. But absolutely, the lead investigators will always keep in contact with the complainant so that they are liaising with them about any possible delays that will come up. What we've also provided as information is assurance that for all contacts that are made with regards to any complaint received, we are acknowledging those within a 3-day working period. So that's very useful to know that actually people who do make that contact are acknowledged and actually have contact with us as an organization. Otherwise, it's really difficult if you're trying to complain and at the first hurdle, no one actually responds to you. Other information that's contained within this report is the learning that we have from complaints. And again, within the Complaints Review Committee, we actually have cases that we go through. This last one, we went through one case where we actually have the lead investigator present, and there's some good confirm and challenge, including the actions taken forward for learning. We've provided within this report an update on our feedback. So we have successfully moved to our new system, Equivia. And whilst there was a dip in what was reported as the feedback, that was because it was going across 2 systems, but we're now starting to see an increase in the feedback that's being provided through to the new system. There's ongoing work to make this easier for people to use, so we will provide more information on that. And as Julia has mentioned, there was a deep dive into this new system. So actually, we do have plans in place to be able to respond to feedback that's provided, as well as increase the uptake of feedback that we are receiving. We've provided information on compliments that we have received. And then the last bit that we provided information on within the report was actually to do with our involvement. So within our involvement team, a lot of work has been happening, especially around our reward and recognition. So we do have some workshops lined up for next month in January. And certainly we have an outstanding action that we need to report to audit committee in February around aligning our processes for rewards and remuneration. So we are on track to be able to report on having completed that action. We continue work around our carer strategy review. And again, we will provide a further update to our quality and safety committee next month on the work that we are doing around this. So this is the report that I'm presenting to Trust Board, and ask that you are assured that we continue to learn from any complaints, any concerns raised within the organization, and we want to improve our services for those who use them through receiving feedback and the work that we do with our patients, their carers and representatives. Thank you, Chair.
Thank you, Linda. I think that I'd certainly like to pick up a couple of points myself. There might be other comments. I just, probably not for discussion now, but I really would like us to think very carefully about how we distinguish between involvees and volunteers in anything we do on reward and recognition of involvees, because I think that has potential to be complicated. So I don't know whether that's been factored in, but I would ask that it is, because I would certainly like some assurance that that is addressed, because it has been an issue, I think, for us. So that's a comment I'd make, and maybe Chris could support that, Chris, because I think you probably recognise why I think, you know, there's such a range of different people doing different roles, that if, for example, you have people doing both roles, involvement and volunteering, I just want to be absolutely clear that what constitutes what. So that piece of work needs to be really carefully undertaken. The second comment, or question really, is about the longest overdue action, page 4, is from a case in February 2022 related to the diabetic foot service. So I suppose I'm just trying to understand why there is an action outstanding from a complaint that is backdates to February 22 and what we're doing to close that. Is that I mean, I don't know whether the complaints committee can look at that and comment back, because there really shouldn't be something that's outstanding for that long. Linda, are you able to comment?
Yeah, I can come in and comment on that, Krishni. So when we looked at the diabetic foot service, and I'll go and check specifically around that, I know there was some actions around commissioning, so I will go and check, and actually we can look into it further within our complaints, within the complaints review committee. But I will go and pick that up. Thank you.
Okay, thank you very much. And I think that's all I wanted to raise. Anything else that anyone wants to comment on? Great, thank you very much, Linda. Oh, Linda, you want to come back in?
Yeah, I just wanted to provide assurance with regards to distinguishing the involvees and volunteers. We have done that. We also were able to get legal guidance around that, which Richard Smith supported. Thank you very much for that. And the process we've introduced will be, that we're proposing to introduce as a tiered system. So that system recognizes those who will be rewarded through the various stages. And some of that is non-financial remuneration, because they are